So welcome back, and we're ready to start day 2 of our 2.5-day workshop, and it's been an interesting experience so far, and I hope we've stimulated your thinking a little bit. As a starter to help us get our thinking going this morning, I wanted to share a word with you from the indigenous language of Aymara. As you know from yesterday, our work started on the Altiplano of Bolivia, working with the indigenous Aymara people, a very proud people who still have a very strong culture. And it was not easy working with these people because they're very suspicious of outsiders, understandably so. But my son, Baker, who was 7 years old when we moved to Bolivia, over the years became fluent in Aymara. And he studied Aymara in college when he lived in Bolivia for a semester. And so about 15 years ago, he started signing all of his emails with this word you see here. And I'm going to let Nat Robinson pronounce this word for you, except you can't see it. At least I can't see it. Good. So, and the word means it would always be good for us to communicate among ourselves. So Nat, come show us, tell us how this word is actually pronounced.
Aruski pasip hananin hanana kasaki puniraki pawa.
So I think this is a wonderful word because the meaning of it has such value to it, and we don't often take enough time to talk among ourselves about important issues, and that's part of what this workshop is about. So we have plenty of time now on our schedule to reflect and talk about what you heard and learned yesterday. So what I'm hoping we can do is have an interactive discussion, and we'd like for you to speak up. And so if you would like to speak, let Andrew know and we'll give you a chance to speak. If you want to put a message in the chat box, that's okay too. But now that you've had a chance to reflect on yesterday and a good night's sleep, we'd like to hear from any of you about things that you learned yesterday that were new to you, or perhaps you were disappointed about not hearing about something, or something didn't seem quite right, or something really energized you. So please speak up and let us know if you'd like to speak as well if you're online. If you don't come up, I'll call on you. Come on up. So our first commenter is Dr. Ramiro Yankee, who you met yesterday, the director of our Cure America's work in Bolivia.
Good morning. I think one of the reflections or main aspects we talked about yesterday is about community health workers. I think community health workers have been one of the common pillars of our programs, community programs, and all of us, we have been thinking about how to keep and maintain them motivated and keep them in the program with the same motivation and the same knowledge, and thinking about always about their sustainability.
Okay, thank you, Ramiro. So let me make a comment about that. Community health workers have been around for a century now, The first community health workers were in China in the 1930s, became barefoot doctors. The idea was picked up in the 60s in Guatemala, actually in the area where our project is, Huehuetenango. And we even had in our Guatemala project area one of the original promoters that was trained back in the 60s or 70s by the Maryknoll sisters of Huehuetenango, who started the promoter program. The community health worker idea spread to Bangladesh in India back in the 70s and 80s, but there has been an ongoing concern and debate about whether this is a good approach or not. And then the Declaration of Almaty in 1978, there was a specific reference to community health workers as part of a health team that was essential for being able to deliver primary health care to people where they are. However, in the early 80s, there were several attempts to scale up community health worker programs nationally, and there were some spectacular failures of that for several reasons. Lack of proper planning, lack of adequate financing at the national level. And so the whole idea kind of fell into disrepute to some degree in the 70s, late 70s, early 80s. But then in the late 90s and early 2000s, there were beginning to be very effective national programs. Bangladesh is certainly an example of that. In India, the JomKid program, as I mentioned yesterday, served as a model for a scale up in the 80s that turned out to be a spectacular failure for the very reasons I mentioned: lack of adequate planning and lack of political support for the money needed to keep these things going. Brazil had a spectacular success in its community health worker program. In the early 1980s, there was in the poorest part of Brazil, northeastern Brazil in Recife, there was a community health agent program that started that was very successful. And over a 20 to 30 year period, this gradually scaled up through all of Brazil and serves all of the population of the country that's not enrolled in private health insurance. And that program involves visitation of every home on a monthly basis. And Brazil has had spectacular improvements in its national health statistics. And in fact, over the past 20 years, it's been along with Bangladesh, has been one of the stars in terms of improving health. Nepal is another example of successful national community health worker program. The female community health volunteers have been a spectacular success. We've talked about Bangladesh and Ethiopia yesterday. So all of these examples are leading to a point right now where I think there's virtually unanimous agreement that we cannot achieve universal health coverage without a strong community health worker program. The debate now is whether or not we're going to be able to fund these programs at large scale. So I've been involved in this debate a little bit, and of course there's a big debate about to what extent it is appropriate and just to rely on volunteers versus paid workers. And so that's another part of the dynamic. But one of the things that I have been struck with over the last 10 years or so is how little attention is given to the amount of money that governments spend on primary health care and community outreach as part of primary health care compared to how much they're spending on hospitals and higher level facilities. There's not information about that. And so my basic position on that is that we need to have better metrics about how governments are spending their money, and we need to somehow bring about a process in which there is pressure on governments to expand the rate of increase in expenditures for community outreach that's at a faster rate than what is being spent on hospitals. The amount of money that government spend on hospitals is not well understood, but one of the things that I have come to conclude that there is so much political pressure on governments to spend more on hospitals and higher level facilities for a number of reasons. But one of them is that everybody wants high level technical care like Johns Hopkins Hospital with new MRIs and new this and that, which are very expensive, these technological things. There are a lot of people employed at those levels, and particularly doctors and higher level nurses can go on strike to get a better salary. And there's a lot of pressure to keep the facilities updated, and that takes a lot of money. And there's no similar political pressure that makes it into decision makers for expanding community-based approaches. And it's a very interesting issue to me. And I think it's hopefully something that'll receive more attention as we move forward. But there are a lot of international groups now that are working with governments to help them figure out how to expand their investments in community health worker programs. The common response within governments is we don't have the money to fund these things. But in fact, if they realized how much money they were putting into higher levels of services, and if they could bring the political process to bear to shift some of that money into the community outreach, then I think we can make some progress. But it's a hard sell, but it's going to continue to move forward in this direction, I'm pretty sure. So that's a long-winded comment to your comment, but obviously we cannot do CBIO without some very strong local presence on the ground. And I'm a great fan personally of the dual cadre system of community health workers, in which you have what are now called professionalized community health workers, meaning workers who have had some significant training, 6 months to a year, who work full time, who are paid a salary, and those people working with a large number of volunteers who may be responsible for 10 or 12 households who work only a small amount of time as volunteers. And the system in Ethiopia is a great example of that that's gone to scale, where you have health extension workers who have 1 year of training. They're paid by the government $80 a month, and they work with a group of women called Health Development Army, who each have 10 to 15 households. And so together that team can be very powerful. And you heard a little bit yesterday about the dual cadre community health worker system that BRAC has in Bangladesh, with the Shasta Shabikas being the lower level, more or less volunteer but minimally paid worker with 6 weeks of training and work a small amount of time, and the full-time Shasta Corbys who support and work with the Shasta Shabikas. So thank you very much for that, Ramiro. So who else wants to make a comment, ask a question, or some reflection?
I see that Mr. Arwal's hand is raised. Mr. Arwal's hand is raised.
Okay, so yeah, Arwal, we've been hearing a lot from Arwal, so we're very grateful to you, Arwal, for that.
Thank you so much, and good morning to everybody here. I'm sorry because of I received the link a little late, so therefore I joined it late. And yes, have you heard me, Dr. Henry Perry?
I can't hear
You
him.
can hear it, yeah.
Yeah, okay.
Speak a little more loudly, please. I'm having
okay.
trouble. I'm hard of hearing.
Okay. So what you're talking and your comments about means the team comments about the community health workers. Let me just to say about the community health worker program in Afghanistan. Actually, I have started in Afghanistan in 1996, this community health volunteer program in Afghanistan. And we trained around few hundred of the.
Hold on. Somebody needs to mute.
Can you please mute your microphone if you're joining in online?
I don't think they can hear us because they're actually.
Oh, sorry. Could you see me? Could you hear from me now?
Yeah, go ahead.
Okay. So as I said, in Afghanistan, we have started in 1996 training of village health volunteer at that time by the name of VHV, Village Health Volunteer. And we trained that in a pilot project of primary health care in Afghanistan. And then after that, in 2002, we was able to have a standard and national policy and strategy for the training of community health workers in all over in the country. So up to now, I can say we train more than 30,000 of this volunteer in a national-wide. And this was one of the successful program of the health volunteer in the region, because this was national program under the government leadership in role of the government. And this was the very nice and according to the experience of Bangladesh, Prague, in Indonesia, and we copied something from there, and we trained there in Afghanistan. And we have for this community health program a few elements. One of that was community health workers, other was the community health councils or shura, and the third was community health by the name of Women Action Group, but we changed in context of Afghanistan by the name of Family Health Action Group in Afghanistan. This was the one of the option which was copied by future generation to Afghanistan, and now we have more than 15,000 of group of the family health action groups. So this was really very successful program, and most of them till the end of this 2021, sorry, they are volunteers. And I'm really surprised, and now they have contact with me, and they are very worried about their future, because now they leave out of the support, out of the supervision and monitoring. But we hope, I'm thinking of this, and I will talk with Dr. Henry Piri and other experts. So how can we follow this program to at least to be live in Afghanistan? Thank you so much. I don't want to have more, but this is the really this one of the strategy of Almaty Declaration for the community participation, to use the community health worker or community health based program. So this is very important, and all of you have this experience, and thank you so much. I don't want to have your more time.
Thank you, Arwal. So I want to follow up on some of your comments there. But I have been aware of the debate that went on in Afghanistan when after the fall of the Taliban, when massive foreign aid came in and a community health worker program was established, there was a lot of debate about whether or not those community health workers should be paid or not. And there was a lot of donor money that was coming in. And so the funds were there, from what I understand. But the concern was that if we pay these people now, once the foreign aid leaves, the government will not be able to continue to provide the salary support for these people. And so as a result, the decision was made to make this a volunteer cadre. Is that right, Arwal?
Yeah, that was the correctly why, because of the future of program it should be sustainable. And for the feeling of the ownership by the community, we try to keep it as volunteer, because in the future, the government was, most of the health fund was from the donor side. And
Right.
for the future, we was not sure that it will be followed by if we pay them. So therefore, we leave that as volunteer as it was.
So this is a very important theme related to the expansion and national implementation of community health worker programs. There's, among the donor community, there is an understanding of the need for community health workers, but there's not a similar political support within the governments, generally speaking, for putting serious money into these. And so the conundrum for the donor community is, should we help countries develop community health worker programs and provide money for the salaries of these people if the government itself is not willing to provide sustaining and ongoing support for these people? And so if we start with salary support that's arising from donor support, and then we can't keep it going, then we're shooting ourselves in the foot, in a sense. So it's an important issue. But I wanted to ask you, Arwal, as time has moved on over the years, what kind of incentives did the volunteers receive? They're not salaried, we understand that, but were they able to receive any kind of financial remuneration or any other kind of support, non-financial perhaps? I know many times going to trainings are things that community health workers can receive some payment for that is a little bit beyond what the cost of actually going to the training is. But can you comment on that?
Yeah, as you know that in Afghanistan and maybe in some other developing countries, we have some NIDs, National Immunization Days, and some other type of the national health days. So the volunteer need to go to the communities and to the society and to train them or to give some health education or vaccination. So at that time, they are paying some things according to the role of, and this payment is from WHO and UNICEF at those days, national days. So they only receive this. This is maybe in few months once or each month once. So these are this type of the money they receive for them.
Okay, great. So let me ask you another question. Given the fact that these people have minimal financial remuneration, what has been the long-term participation of community health workers in Afghanistan? What has been the turnover of community health workers? Can you comment on that?
Actually, from the beginning, this was very important that we are not promised them that we will pay them something. And we give them the inspirations, and the community leaders was agree for the given as some person who are volunteer and work following by volunteers. So therefore, they are not mostly, but sometimes just only we try to pay, for example, if they are coming from the rural area to some urban area or some area to it is far from them for the training or something. So we are paying some that costs not as a salary or incentive. So this is following it. This is for the time being. Only, sorry, only they wanted from us the monthly kits. We provide him the monthly kit of some medicine, and some the instrument what was needed for them to follow their basic health activities in the, for example, dressing materials or something else. So, but unfortunately, this since the Taliban is coming in, the only WHO supporting the local NGO in the area for the health service, those NGOs give some less things, not the complete kits, but they providing some at least in some area, not all over in the national wides.
So one might think that keeping these community health workers unsalaried and minimally incentivized in Afghanistan might have been a good policy in a sense, because with the change of governments after the United States withdrew from Afghanistan, there would not have been money to pay these people if they were receiving a salary. Is that right?
Yeah, this was our our concern at that time. Also, even some of the partners and donors was saying no, they should pay, but we will believe that in the future it will be more difficult and not sustainable. So now, you know that Dr. Hani Piri, even now every night I receive some call from these people from Afghanistan. And still they are working, still they are asking what should we do and how we should do. And I promise them, please wait and just you follow your work. And once we will be able to, we will get some sources to follow, at least to, even they now waiting for me for every years, they get refresher training. So this is the things that still we have this around of 30,000 CW. They are active in their area, in their village. Even if they not receive, at least they are doing their health education there.
So for those of you who probably do not know this, but over the last 15, 20 years, after the collapse of the Taliban, Afghanistan has made dramatic progress in terms of improving the health of its people, and the community health worker program has been a vital part of that success. And Arwal has been leading that community-based primary health care work for the Ministry of Health up until just recently, 2 years ago. One of the interesting things to me is that in ministries of health around the world, the positions of authority tend to be related, and the money tends to be related to disease-specific programs. And there are very few ministries of health where you have an office of primary health care or even an office of community-based primary health care. And Arwal was able to start the first office of community-based primary health care that I'm aware of anywhere in the world, but within the Ministry of Health within Afghanistan. You want to say a comment about that, Arwal?
Yeah, that was in 2003, we were able to officially convince the leadership of Minister of Public Health and to have to give us one office officially and include that an official organogram of the Minister of Public Health. So that was, and after that we are following. You know that monthly all CHW or community health workers give their report to the HMIS of Ministry of Public Health. I mean, they are now officially include their report in the, but at this time, of course, there is problem, you know that.
So one final comment, well, I guess two final comments on this useful discussion, I think. One is that I was a part of the creation of a 478-page document that describes national community health worker programs in 29 countries. And Arwal and some of his other colleagues wrote the chapter on Afghanistan's community health worker program. It's a very inspiring and uplifting story. The references available online. It's a book that you can download. It's not widely known, but it's a very valuable resource, I think. The other comment I wanted to make is that I'm passionate about community health workers and their importance in helping health programs expand their coverage of services and improve the impact of a health program on the health of the population they serve. But with all of the growing interest in strengthening community health worker programs, there's not as much attention given as there should be, I don't think, to the specific tasks that a community health worker should carry out, how those tasks are defined, how a community health worker should best organize his work or her work within a community. There's a very complex set of issues to be faced there. And one of the interesting findings, in my view, related to all this is that there has been a very major push from UNICEF and the World Health Organization called something called ICCM, which stands for Integrated Community Case Management. And what that is the community health workers being trained to detect and treat diarrhea, pneumonia and malaria and malnutrition at the community level. And it's so obvious that that's important, but the research that's been done on the effectiveness of this program has shown that even when they're out there and they're trained, only 20% of the children who need those services from a community health worker actually receive them. And that's why the program that R.A. Johnson spoke about yesterday, in which they have community health workers going every home looking for children who need treatment, is so much more powerful than simply having a community health worker with training who's not reaching out to the households. In Ethiopia, for example, a very dispersed rural population, within the catchment area of a community health worker, for 2,500 people, a community health worker may need to walk more than an hour or even 2 hours to reach the households within his catchment area. And so that's why I think we need a dual cadre system, so that a community health worker who's fully trained and supported can link in with other volunteers who are much more closely connected to their households. One final thing is that I was also part of a group that has published a journal supplement on community health workers, which you might be interested in. These will all be available on our website, by the way, and you'll hear more about that later today. But we have a journal supplement. The title of it is Community Health Workers at the Dawn of a New Era. And it's all based on the simple idea that there is a growing awareness of the absolute necessity to build strong community health worker programs for health systems anywhere, including the United States. And this is another area of great interest and growth at present. So if we can make the case, which a lot of people are doing now, that community health workers are a vital component of the health system in the United States, then obviously they're important for other countries as well. So we have some chat questions coming in. Andrew, can you help me?
Yeah, I'll take the mic from you. So we have a comment from Michael Tetty. Good morning, Dr. Perry. What I learned yesterday was that CBIO requires commitment from the project staff, commitment to keep going so as to build trust. They also have to be adaptable, think outside the box, and be ready to try new ideas. Be transparent so as to build trust among the community. Following on from my earlier comment, the challenge is how to maintain the level of commitment among the project staff without pay. We also have a hand raised whenever you're ready.
Okay, well, that's a great comment and a great question. And so I'd like to throw that question out to you all to see who might want to make a comment on it. In particular, some of our team who are here from Bolivia and Guatemala and Kenya. Who would like to respond to that question and the issue? How to keep going when the going gets tough? Anybody online like to respond to that? If so, raise your hand.
Well, Dr. Perry.
Yes.
This is Michael Tete. I posed the question, and I would like to make an observation based on my experience in Sierra Leone.
Great.
I worked with the Methodist Church in Sierra Leone with the hospital, with the mission hospital. When I went, we realized that, as you stated earlier in the paper, and also as many of your previous speakers have stated, we were not getting the community to come to the hospital because it was obviously sedentary, it was far, and roads were, especially in the rainy season, not very good. So they couldn't travel. In addition, they didn't have the money, even though the cost of treatment was very minimal, just to cover basic material. So what we decided to do was to set up a mobile clinic. So we traveled to various villages each day of the week, different village, and we set up a clinic, and then we, following the clinic, we'll bring onto the hospital with the hospital ambulance those patients who we thought required extra treatment at the hospital. And so that was how we got most of the villages or the community rather, to come to the hospital. And this was done at a very subsidized rate. We had some funding from a few NGOs, but mostly we looked after our funding properly, our income properly, and we used some of that to fund the mobile clinic. What we realized, though, was that our staff were then building relationships with patients, and therefore, instead of directing patients into the hospital, we're treating the patients at home. So they were basically generating their own income to supplement their salary. And so eventually we realized that we were not getting as many patients as we thought we would, because these patients were being diverted to individual homes. To keep those going, we decided, those who were on the project, to keep them going, we decided to incentivize them by giving them bonuses at the end of period. The bonuses were not necessarily financial. They could be the best worker of the month, or the whatever we thought was appropriate at a particular time. So we had to use a lot of ingenuity and innovations to motivate our staff to do the work. But it was hard going, because in a situation where poverty is very high, money was always the deciding factor. And eventually, when I left, I was told that the mobile clinic program died.
Okay, well, you've raised some interesting issues here. Mobile clinics take money, of course, for transport and motivating staff to get out into the difficult to reach areas. There are many examples around the world of mobile teams that go out to do various things: immunizations, family planning programs, and treatment of acute illness, and provision of prenatal care and family planning and so forth. And those certainly have a value related to them. Bangladesh has had a long history of so-called satellite clinics where a mobile team will go once a month to various places so they can get around. So those are examples of what I was referring to yesterday when I talked about the three legs of the stool of public health: the vertical disease-oriented programs, the services-oriented public health programs, and then the community-oriented public health programs. So the mobile clinics are getting basic and essential services closer to the people. Many of those are vertical disease control programs, family planning, immunizations, and so forth. And they certainly have a value. CBIO, in my view, brings an additional value that goes beyond what a mobile clinic can do. A mobile clinic, we have great examples from Guatemala of mobile clinics that went into the community to provide certain basic services. So there are several aspects in which CBIO brings value that mobile clinics can't provide. So the first thing that I was going to mention is that to emphasize your point of the difficulty that people have reaching facilities, whether it's a primary healthcare center or a hospital, there are many studies that show that the likelihood of a family, of a person utilizing a health facility or a hospital diminishes exponentially with your distance away from it. And so if you live further away from a health facility, it takes a lot of effort to get to that facility. And also the people who live further away are likely to be less educated, poor, less aware of the value of utilizing health services. And so this issue of equity is a very important one. And even with mobile clinics, they're likely to go to places where still, and of course it varies from country to country and in rural areas, but there's still likely to be a significant distance involved in reaching to where the mobile clinic is. So for all those reasons, and the other thing is that it's hard for a mobile clinic and the staff there to promote healthy household behaviors and preventive kinds of things that are so important, which is one of the great values of care groups that we'll be hearing about in the afternoon. That's very difficult to do with the mobile team that gets absorbed with the busyness of providing acute care and immunizations or family planning. So the value of routine systematic home visitation, particularly for the preventive medicine approaches, household behaviors, helping people understand what the warning signs are, particularly for children and women who are pregnant. All of those things are very difficult to achieve at a health facility and even with the mobile team. So it's interesting to hear you say that the mobile team program stopped. It's just another example of the challenges of developing strong outreach programs when there's so much pressure and demand to put those resources into higher level facilities.
There's Dr. Orji has his hand raised, so you can just welcome him to open his screen.
Okay, so we have somebody with his hand raised. So, oh.
Yeah.
Okay, go ahead, Brayton.
Yeah, Perry, this is Bright. So thank you so much for providing this insight. My question actually is like a follow-up what Michael has asked, looking at other models of paying the community health workers. In Nigeria, we have seen several models, but none of them appears to be sustainable. So what the Nigerian government is trying to do at this time is to provide the community health workers with the skills, entrepreneurship skills, and then help them have access to microfinancing loan, soft loan. So they could actually build a business of their own, and from the business make profits that will keep them going and also ensuring that services are delivered. But we're just trying this out. So it is at its preliminary early stages. I want to see in the next 2 years how this will work out and how sustainable it will be, just to provide this aspect of it, supporting the community. Thank you.
Great. So thank you very much. There are throughout the world a number of innovative approaches to try to generate funds at the local level that can support and motivate community health workers, and creating microfinance groups among community health workers is one of a number of different ideas that are floating around out there. And there is a lot of potential for generating resources at the local level or at the district level to support community health work that may not be available at the national level. And I think generally in most countries, there is now becoming more funding available at local levels to support primary health care. So those funds can be one source of support to help provide further motivation for community health workers. We're really having a great discussion, so I wasn't quite sure whether this would work out or not, but it's been great. Going back to an earlier question about how to keep these kinds of programs going when the going gets tough. One of the important parts, I think, of building strong community-oriented public health programs is leadership. And it takes very committed, passionate, very capable people to lead these kinds of programs and to keep them going. And so I think one of the important issues for us moving forward, in fact, we're going to be talking about this later this morning, about how we can build a stronger momentum for expanding this approach throughout the world. But one of the ways of doing that, I think, is by fostering leadership of people who are young and see the value of this and are willing to make a commitment to expanding this kind of work. Are there any other comments or questions? Andrew has something, I think.
Yes, one more question from Adam Paul. I'm working at an orphanage at the City of Hope at Amman Medical Center, but many patients come from different places. Many people are poor, using local medicine. How will CBIO going to help the community like this and others who are not rich at the hospital?
So is this in Jordan, Amman, Jordan? I guess it is. Well, that's an interesting question. Obviously, if you're dealing with a population of children who come from another location in an orphanage, then you can think of the orphanage as a community, I guess, as a defined population of people. And within that group of children, go through the CBIO process of community diagnosis, defining their epidemiological priorities and what their priorities are for their health. That's certainly one way to do it. You can think of communities not necessarily in a geographically defined population, which is the way we talk about it, but it can be other groups of people that come together for some reason or another, and children in an orphanage is one way of thinking of a community that we wouldn't ordinarily think of. But I don't see how a health program within an orphanage can really do anything of real substance to reach out to the communities where these orphans came from, since they come from a long distance. Any other comments or questions?
Mario.
Okay, Mario Valdez is going to come and make a comment in Spanish. So hopefully, you have to put yourself in the English language channel, I think. So Mario.
Sí, solo para ir aclarando en relación a promotores y el financiamiento. A mí me parece que en esta situación de desaprender es importante ir cambiando, que el primer nivel es el más sencillo, es el que se le debe invertir menos, es donde solamente debe haber un puesto y un auxiliar. No, el primer nivel es complejo. El primer nivel necesita también financiamiento. Y el primer nivel es como la base de un edificio en la cual requiere inversión y que también es complejo.
Great, thank you. There's a lot of awareness that's growing now of the need to consider the community and the household in particular as the basic element of a health system. And that hasn't been the case traditionally over time. So Mario and his team are certainly leaders in moving that idea forward. Okay, well, our time is up for this. So we'll take a couple of minutes break and then we'll move into the next section, which is going to be a 2-hour session. We'll probably take a break in the middle of that, talking about what I consider to be technical components of CBIO. So we'll be back in 2 or 3 minutes.
Oh, they're right up here. What the hell is he? Oh my gosh, it's a busy day already. Program manager there, and I work with our partners in Kenya, which we have in Guatemala, and back home in Mario. And then I coordinate some of the related projects, but they've been around about 4 years. They don't have so much technical stuff anymore. You know, like I'm excited to have another person in person. A lot of people are around the world, so.
Can you move that so it's not some corner or something?
They have the slide presentation.
Oh, good. Okay, I think we're ready to start. This is going to be a rather lengthy session, and I hope that we'll continue to have questions and comments as we move along, and it'll certainly enrich our discussion of these issues. So I call this the technical components of CBIO. My screen's frozen. I need technical help. Sorry. Why does it do that? How do I keep that from happening?
Doesn't work.
Okay, so what we're going to talk about right now is an overview again of the CBIO elements, which I think are important to continue to go back to again and again and again because they're so fundamental but easy to lose sight of. Getting started with CBIO, measuring baseline health status, defining the community's priorities and the epidemiological priorities, some discussion about program implementation, and then assessing progress over time. So if you did your homework, I'm not going to ask for hands of how many people did their homework, but I hope at least some of you did. If you read the article on CBIO, one of the important elements of starting CBIO is something that we call in the article exploratory and then later pilot program planning. In our experience at Cure Americas, this step has frequently been underemphasized, relatively neglected, or totally ignored. And there's an important reason for that is because generally we've had a grant that requires getting started very quickly. And so the slow process of exploratory and pilot program planning isn't really possible based on the timelines that we get forced into with the grants. So sometimes in a way, grants can be somewhat self-defeating from the standpoint of implementing a strong CBIO program. We have a long history at Cure Americas of receiving child survival grants from the United States Agency for International Development. They had for 3 decades a program that doesn't exist anymore, unfortunately, but it had a lot of special features to it that enable us to strengthen our own programming, and particularly with the CBIO focus. One of them was that if you got a 4-year grant, for example, the program was set up in such a way, the funding program was set up in such a way that you were required as a recipient of the grant to do a household survey of your program after you got your grant. So you have your money and you're required to do a household survey of the area where your project's going to be. And based on the findings from your household survey, as well as based on the experience and knowledge you obtained after you got your money and you hired your first staff to get to know the program area, that led to the development of something called a detailed implementation plan. And projects generally had 9 months to develop that. And that detailed program implementation plan had to be reviewed by an external review committee that AID set up through its program. And it was a very powerful tool, I think, to build a stronger program. And it also embedded in that was a requirement that you do a baseline household survey. I'm going to be talking about household surveys more as we go through the day today and tomorrow. But one of the interesting things to me that I've observed over a long period of time, and this goes back to 1987 when we started this this type of work with AID. Back at that time in the 80s, when NGOs were told they had to do a household survey, then they hired some external expert to come in and do this and guide the survey and run the process for how to do it, train the interviewers, and analyze the results. Over 3 decades, more than 3 decades, I've observed that NGOs who had these types of programs developed their own internal capacity to do these surveys on their own. And our team in Guatemala is a great example of that, where under Mario's leadership, their own staff developed the capacity to design a survey, choose a sample that's appropriate and scientifically valid, train the interviewers, go out and collect the data, and then analyze it yourself. And so I think there's a large potential for helping local programs do household surveys that don't depend on some external source or external money. They're not that complicated to do. And if NGO staff can learn how to do it, I think Ministry of Health staff at the district level can learn how to do it. So I'll be coming back to that later. But this kind of activity is very important as we think about moving forward with CBIO. So if you read the article, we go into some detail about what we mean by these things. But there is something in the article that we call reconnaissance, library reconnaissance, which is an interesting name, I think. I like it. Library sort of reconnaissance is a term that comes from military activities where you send a spy out to check out on the enemy and find out where they are and what they're up to. But it got brought into this sort of public health discourse in the time of John Wyan, and his ideas are reflected in here. So this was his terminology, reconnaissance. So library reconnaissance, where the people involved in designing the program are going to collect whatever information might be available that is relevant to their program area. It may not be specific to that program, but it might be broader information that's available that has relevance for the program. So that's the library reconnaissance part of this, but the field reconnaissance involves going out and talking with people and understanding what the geographic layout of the program area is and all those kinds of things to help formulate ideas about how a program might get started. And then the exploratory program implementation is simply trying out something that makes sense on your knowledge that you developed up to that point on a small scale. So yesterday, if you remember, Dardo Chavez and his wife Meetma made quite a point of how they started out. They were in a peri-urban area, but they started out just in a very small block or two, trying out their approach. And then as it became, through their experience, they were able to modify it in a way that made it more appropriate to scale up. When I say scale up, I mean their program serves 30,000 people. So we're not talking about a massive scale up, but they started very slowly at a very small scale. And so I think this is a valuable principle to think about. Then after exploratory program implementation, we have what we call pilot program implementation, which would be on a little bit larger scale than on the exploratory program implementation level, and then implementing that, and then through that experience, developing a larger scale activity. And this takes time, and developing the data collection tools, developing the training materials, all of this stuff is not easy and takes time. And actually, while I'm thinking about it, Barbara, why don't you come up here and tell us all a little bit about some of what you've gone through in helping Haiti get started.
Sure.
So this is Barbara Mufuletto, our program manager, and she's been involved for several years now in helping to start a CBIO program in Haiti. And in fact, our Haitian director of this is online, and maybe he might want to share a few comments as well. So you take that.
Thank you, Henry. And yes, I agree. We should see if Anais would have anything he would like to share as well. So Cure Americas Global started a partnership with Haiti Outreach Ministries a few years back. And with this partnership, we are implementing the CBIO methodology, which, as we will learn more about today, begins with this kind of not library reconnaissance, but
field reconnaissance.
Field reconnaissance. where you do a census of the population and also gather information about health behaviors, health knowledge, and health outcomes. So this is Cure America's first, or at least my first experience working on starting a project in a peri-urban area and a relatively unstable peri-urban area where there is lots of in-migration, out-migration, a relatively recent presidential assassination, which was preceded by mass protests around the country and has then been followed by a lot of gang violence. So this has been a very interesting place to test out CBIO. We are currently going, we completed our like demographic census last year. And now we are going and doing, we've been calling it an indicator census. Our project area is small enough that it made more sense to just go to every household again to collect mortality data and get kind of a KPC, a knowledge practice coverage survey data to collect our baseline information. So we are currently in the process of collecting that information, and maybe Anais can speak to some of his experiences with that. I don't know if he could speak maybe in French, and then we can have the translators translate for him.
Yes. Anais, would you please share a few comments with us if you can? He's signed in from Haiti.
Yeah, he's the one in the yellow shirt. But he may not. Is he speaking?
Is he trying to speak?
Much more comfortable.
So you'll need to turn your English channel on.
He needs to unmute. Mute footprint.
I ask a question, Aaron.
I hear you. I think you'll be best if you can switch
So go ahead, Anais. We heard you very briefly, but then it stopped. So go ahead and share any thoughts you have about starting CBIO in a small population of 5,000 people in a peri-urban area of Haiti.
Hello?
Yes, we hear you now. And you can speak in French, of course.
So when we start the CBIO project, did you hear me? You hear me?
Yes, go ahead.
When we start the CBIO project, things we did, we do the cartography of the area we focus on. And after the cartography, we are going to talk with the partnership, the population, the leaders on the community, like the personal professional, the doctor, the teacher, the advocate, everybody on the community. First things we create if committee members is including the voluntary 3 person. And after the committee members, we are talking to the women of the community, different partners, and then we choose the model indicators. So after the model indicators, we do the census based on the area. So we collect the data about each household information. And after the information we create, the different groups. We have a total 14 groups, neighborhood groups, plus 14 models educators actively. They are working volunteer on the community. When I'm talking to you right now, I have 2 different activities on my team. The team working, we have the team working, we have the team. One is work to meet the moderate characters and assist the neighboring groups, meaning one is working at the same time to design census. So the baseline census will be done this month. And then after that, Baba will send you the reports. And then we're collecting some picture videos, like just to prove what we do on the in Haiti.
Difficult. Aeneas, we're going to cut you off here. Unfortunately, we're not able to interpret what you're saying. Barbara, did you understand anything at all out of that that you could share?
I would just have him put it in the chat, and then we can continue that way. I don't want to misspeak.
Okay, you're going to ask him to put it in the chat?
Yeah.
Okay, so we're asking him to write this out in the chat so that you'll be able to see that. I apologize for that. Anyway, it's easy to think of starting CBIO as simply doing a census and making a map, and then that's it. But there are a lot of other steps involved to this to think about how to develop the program, the operational parts of it that will work within the context. And so I think in general, in my experience and the experience of our programs, we haven't given sufficient attention to really thinking through carefully how a CBIO program could best function within the constraints of a context in which the program is being implemented. So based on the exploratory program planning and implementation, pilot program planning and implementation, then in theory, you're ready to move into the definitive program stage, which involves a formal community diagnosis, then planning the program and then implementing it. And then after some period of time, we say in the article 5 to 7 years, carrying out a program evaluation and a community re-diagnosis. Like I said in the beginning, theory and practice are closer in theory than practice. So all of us who have been involved in this find ourselves having to not necessarily follow the strict ideas of CBIO, but still keeping them in mind, I think, is terribly important. So the priorities at the outset of starting a program involve developing a relationship of trust between the health program and the community. And this is a theme that has come up repeatedly. We heard it yesterday many times. And so I'm wondering, among those who are attending here, what are the ways in which we can develop trust with the community? Would somebody like to share some ideas on that? So if you can, unmute yourself and speak into the microphone, or if you're in the room, come on up here. What are ways in which we can develop trust between the health program and the community?
I just want to mention Troy Bannon, who is the executive director of Haiti, our project in Haiti, said he'd be happy to speak.
About Haiti?
Yes, and Anais's audio is a little trouble.
Okay, we're going to take just a brief step backwards, back to Haiti. One of our other Haitian staff is on the line, and Barbara will explain what's going to happen now.
Hi, so I would like to invite Troy, if you could unmute, and I believe Troy will be in the English channel. If you prefer French, just let us know and we can make sure that is set up.
French, English would be fine.
Excellent.
All right, thanks a lot. Everyone, can you guys hear me?
Yes, we can. Go ahead.
I think Anna was trying to share with you guys the wonderful experience that we had with the census. In the beginning, since it has been there is not, it's right in the middle of the city, and Cité Soleil, a very tough environment. We had questions about whether or not not a lot of money being involved in the program was going to be a problem. At the end, it worked out very well because the community got involved and participated in the census, and now we have a very strong team on the field. I visited the program last 2 weeks ago, and we have a very strong team of supervisors, agents, who have a very strong connection with the women, with the mothers. So one thing I think I would like to share my experience with this our program in Haiti is that it's a little bit different because I saw CBIO work in Guatemala, and it's a very rural area, and we are in the middle of mountain, behind mountain. But in Haiti, it's different because it's right in the middle of the city. It's the kind of inner city where there is a lot of poverty, and there is a lot of violence, and there is a lack of presence of local government. But what I've learned about it, it's that it worked very well. I was very shocked that the same method that is being worked in Guatemala and a rural area is being well implemented in Haiti, right in Cité Soleil, in a very inner city environment. So, which makes the program very exciting because you could see that it could fit in different settings and have different people participate in. So I don't know why it works that well in Cité Soleil, but I think first, well, in my view, when I saw this the program work in Guatemala, I thought that it was because the infrastructures, the health infrastructures are very far away, like the hospitals, the clinics are a little bit far away, so people have to stay locally to organize their own health. That's not the case. Cité Soleil is very close to everything in Port-au-Prince, but I think CBIO brings an aspect of connection, takes advantage of connection between people and communities, and that benefits Cité Soleil, benefit Haiti a lot, because when there is violence, people don't travel far away for services. When service is not available, people tend to stay in their community and try to find their own solution. And with the CBIO method, they found those solutions inside of the household by participating as mothers, by participating as agents, by participating as supervisors. So it's a great experience. I was amazed by it because it facilitates I think it works in both environments, both rural environments and urban environments.
Okay, Troy, thank you very much. So it wasn't clear perhaps from what he said, but Troy did go to Guatemala to see the work there, and that's another example of the value of actually seeing a functioning program in place to help people get a sense of confidence about what can be done. So I want to come back to the question I raised earlier before we went back to Haiti briefly. What are your thoughts and experience about how to develop trust with the community, between the health program and the community? Who would like to comment on that?
Can I?
So Dr. Ramiro Yankee from Bolivia, the director of our program there, will speak.
So, well, from my personal experience and my experience working for Cure Americas in Bolivia, well, I
25 years ago?
Perhaps a little bit more from my personal experience. I was part of the team in one of the regions of Bolivia that participated in controlling the outbreak of cholera in Bolivia.
This was before you started working with
before Cure Americas. And I remember that many people were dying of cholera in Bolivia. So at first we were trying to control the epidemic remotely, sending messages, key activities to be done at the community level. But afterwards we understood that we needed to go there and to live with the families and communities and to struggle with them with the problem. So so when I was after that working with CSRA, I really got convinced. Yes, Cure Americas.
Cure Americas.
Cure Americas, sorry. And I realized the importance of what we have been talking yesterday about. Live with them. I understood this phrase, which is very important for us, a kind of philosophy. To live with them, to suffer with them, to solve the problem with them, side by side with the community. So I think instead of just thinking about how to involve the community in our activities, implementation, evaluation, it's better to go and live with them and suffer with them.
Thank you, Ramiro. So I want to make a comment about that. Abhai Bang's quotation from this ancient Chinese person of go out and live with the people, love them, learn from them, and so forth. You know, for most of us, that's not a practical reality. I mean, Abhai Bang, he lives in the midst of this project area where they've been for 30 years, but there are very few of us that can actually do that kind of thing. And so the translation of that message for me involves empowering and helping to facilitate people who are already living there to be able to do this work because they're already there, they understand the people, and to bring them involved in the program. And this can be community health workers, but also volunteers and community leaders. So having programs that can engage these people and provide them with support and encouragement to be effective is the translation of that dictum that Abhai Bang shares, and as Ramiro just said, to go to the people and live with them. It's very difficult to get more highly trained health people to go and live in a very isolated rural area. And for people who live within their own country, even in Haiti, I know personally about this, it's very difficult to get a Haitian physician to go and live in a rural area of Haiti. They want to live and they want to have live in the city. They want to be in a larger city where there's better education, where they're not so isolated. And this is true all over the world. And so one great example of this is at the Jamkhed project in India back in the early 70s. They adopted the model of Carl Taylor's at Naringwal that I mentioned, and what they started out with was they hired trained nurses to go and live in the villages and work as community health workers. And what they found out was that these women didn't stay, they left. They were young, unmarried, more highly educated people relative to the community they were working in. So the Arolis made a dramatic shift. Instead of hiring outside, more highly trained people, they decided to work with the women already living in the village. And in their case, what they did was they had developed relationships with many Dalits. A Dalit is an untouchable woman, and many of these women had developed tuberculosis or some illness, and the Arolis had helped bring them back to life. And so they had this relationship with these illiterate women, and they trained them to be community health workers And they're still there 30 years later. Well, some of them have retired, of course, but I mean, they have been long-term collaborators in the foundation of their program. And so that is certainly one way to bring trust into the situation. It's a long-term issue. But anyway, I think it's a great point that you raised, Ramiro, so thank you. I'm wondering if anybody else wants to make a comment about how to develop trust with the community. Kevin Kayando is going to join us now from our project in Kenya we call KICOP.
Hello, again, my name is Kevin Kayando from the KICOP project in Kenya. What I want to say is communities are very sensitive. The moment you don't build trust with communities, that is the end of the project. So you have to be very careful how you want to engage with communities. You don't assume that they need you. That is the first point. You don't assume. As one of the speakers here yesterday said, that communities are the experts. They know their problems. They know what they need. So you need to go to them, talk to them, live with them. I will give a very good example of my colleague Anne Kerubo here, who is always at the communities, talking with moms, talking with clan elders, talking with chiefs, talking with the opinion leaders on how to make the project better. And that's how we have been able to build trust with the communities. We are always involving the community gatekeepers, the community elders, the community opinion leaders, the local administration. That is very key. Another way of building trust between communities is not to promise what you can't give. That is very key, because once you promise what you can't give, that will be the beginning of problems. And it will be a recycling and a never-ending cycle where we'll be reminded, the other day you said this and this is not what happened. Another way of building trust with communities that we discovered is sharing data with them. As KICOP, we've been sharing the data we collect with communities. We involve them in collecting the data. The local leaders, the community leaders help us in mapping the community. They help us in they act as guides when we're collecting baseline data. And so we are able to collect robust, verifiable data because the community is involved. And then we are able to share this data with them. The impact of this and the impact of our interventions are also visible. We involve them and also we are part of the community assemblies. We don't call for community assemblies. We go and form part of community assemblies. Our CHVs form part of the community assemblies. They go and document KICOP's agenda in the community assemblies. And in those assemblies, you are able to hear testimonies of how, for example, a mother used to complain of having malaria every fortnight, and because of KICOP education on using bed nets, they've been able to reduce malaria, and this they've been able to reduce costs. So directly we are impacting economically as well. A mother complaining how he used to get typhoid, but because of the water treatment lessons we are giving them, they are able now to save money. A mother who used to complain of pneumonia and diarrheal diseases, but because of the many hand washing facilities you're able to set up in the communities. So communities are very sensitive, and it's a collaborative aspect. You need to live with them, love them, as well as share data with them, as well as continuing to build trust with honesty and transparency in our programs. Thank you.
Well, that was beautiful. Wow, I'm glad we have that recorded. One of the elements that I think is important in building trust, there are many elements that go into it, but I've seen this in our projects over the years, and that is when the community has a serious health problem, for the program to do what it can to respond to it, even though it may not have the capacity to resolve that problem, but the program can help the person in the village get to some source of care. And that's something that can take a lot of time and effort. And we have a long history of that. And it's not described in the CBIO methodology and so forth, but it's something that's critical in building trust between the program and the community when there's some serious issue, trying to do what might be possible within that circumstance to address that crisis that a family may have or a community may have. So I'm wondering if Ramiro and Mario could say a little bit from your experience and what you've seen and how our programs have tried to help people and getting them from an isolated village into a higher level facility, for example. So can you come up and just share a little bit of that as a way of building trust?
Sí, en relación al programa de Guatemala es muy particular porque la zona en la cual está es muy aislada. Generalmente los trabajadores de salud llegan a vivir a las comunidades. Por supuesto que esto también lleva un poquito de tiempo ir tomando esta confianza con ellos y poder ir trabajando de una forma ya en equipo. Seguro que también, conforme el tiempo ha ido pasando, se ha ido creando pues también de puestos ya comunitarios y actualmente pues también ya se tiene personal del lugar de las comunidades y eso pues favorece porque hay una intervención entre el personal de afuera y ya el personal que es de la comunidad.
The experience that you had working in the field, helping to respond to medical emergencies that arose as a way of building trust. Thank you, Mario. Now, Ramiro Yankee, who worked in the field for a number of years on the rural Altiplano of Bolivia, is going to share a few comments about his experience in building trust by the program helping communities to respond to a medical emergency that might arise, which may not be part of the program of CBIO, but it provides an opportunity to help get somebody with a medical emergency to a higher level of care that they need.
Yes, actually, I was trying to talk about a little bit yesterday, which is also very important for the program. Working in this angle because we have been working with communities, trying to do some activities related to prevention, talking with them with education and empowerment. But if we don't have a health system that can respond to the needs and to respond the demand that we are creating at the community level, our program is going to fail. So these are perhaps some examples of what CBIO was doing in Bolivia about these things. We have been trying to work closely with the health system, with the municipal government and the Ministry of Health, trying to gain their trust and try to have to get the services delegated to us to work on the health system. Actually, we have 2 clinics in one of the regions we have in Montero, and we are providing clinical services. On the other, in which we can control and monitor the quality of health services, and in some other places we need to work closely with health staff, because it's very important for us, for them to receive the demand that we are creating with the community. So, and we have been working closely with them to improve the referral system, for example, to improve the referral system with ambulances in many cases, because we have been working with in very isolated places. So the transportation was very critical to refer an emergency.
Okay, thank you. As we're having this discussion, this is really great. It's so important, and we've got a lot of other things to talk about. But let me share something that happens with the BRAC program in the urban slums that I happen to know about, which is related to building trust with the community, but it brings in the idea of linking to referral systems. We've never operated hospitals. It takes a lot of money to operate a hospital. We've never operated higher level facilities. And so we can't resolve these problems that need higher level care, but we can help get patients who need that to that level and hope for the best. That's all we can do. And of course, as Ramiro said, having a vehicle, it may not, and in many cases, it wasn't an ambulance, so we had a vehicle that could carry a patient to a higher level of care when we're working in isolated rural areas like on the Altiplano. But in the case of BRAC, in the urban slums, and I'm going to show a video about this a little bit later, but it doesn't go into this particular aspect that I want to mention. They have had a system of what are called birth huts, which are simply a room with a mattress on it in a slum. And 2 traditional midwives are hired and trained, given additional training, and they supervise the care of women who come from a population of about 10,000 people into the birth hut to give a birth. So when a complication arises, they have a system of transport set up. Whoa! Somebody needs to mute their microphone, please. Okay, thank you. They have a system of transport set up, which is not a vehicle, but it's just hiring a local rickshaw driver in the city of Dhaka. There are plenty of those around, so the transport's not an issue. But the critical part of this is that BRAC hires someone to be based in the hospital and is notified when the patient is referred from the slums to the hospital. And that person who's on the staff of BRAC is there stationed in the hospital to make sure that that patient receives prompt care. And of course, it happens all over the world, particularly poor people. They get into a situation where they have to give a bribe or make a special payment in order to get care. And when you're in an emergency, you know, people will do anything. And so that person is there to make sure that that person is an advocate for the person who came from the slums at the hospital. But BRAC is not operating the hospital, but they've got the person stationed there. And that's, to me, an important angle of building trust between the people and the program. Is there another comment or question about building trust?
Yeah, 2 comments. Well, we have Billy Gama can unmute and share.
Oh, thank you very much. I'm Reverend Dr. Billy Gama from Malawi. I'm the chairman of Malawi Council of Churches. And as a chairman, Malawi Council of Churches has got 25 denominations and 12 affiliates. The issue of building trust here in Malawi, I think in 2018, an organization from United States of America, they made a research putting people according to their levels of influence, and the religious leaders were put on top to have a larger influence among Malawians. For some people who do not have a little bit of history of Malawi, many politicians in Malawi, the communities don't trust them because they always make false promises. And when they make these promises, especially when it is towards election, once they are elected in political offices, they don't fulfill their promises or manifesto. So for the community to build trust, I would suggest number one, we have to identify among the communities some of the influential leaders within their communities. And number two, those influential leaders within their communities, we should team up, we should partner with them, especially when it comes to health issues, bring a small project, health related. And once that is implemented and the people know that we have fulfilled the promises, they will begin to build trust in us. Then bigger projects can also follow after they have seen that small projects, they were able to be fulfilled. But let me also conclude by commending the CBIO for also inviting us to this important discussion. I find this is very key and very important, and I would love, I think, more to do with that CBI project here in Malawi as well. Let's create more links so that more people can participate in these important discussions. Thank you very much.
Thank you very much for those comments. I want to make one final comment, and then we'll move on to the next points. Was there another question or chat or something? Maybe let's hear that, and I'll make my final comment.
So in the chat from Albert Kalanji, the involvement of community leaders is one of the key factors in creating trust. We noted in DRC that community projects that rely solely on community health workers without strong involvement or accountability from community leaders experienced enormous difficulties.
That's a terrific comment. So thank you very much. And I think we need to be reminded of that. And it's related to the final comment that I wanted to make before we go on to the next session. Has anybody ever heard the term elite capture, ELITE, elite capture? So it's a very interesting concept, and it applies to many different situations everywhere in a way. But the term elite capture refers to the capacity of people with unusual or special influence to take control of the situation that's going to benefit them at the expense of other people. And so Bangladesh is a great example where elite capture was dominant within the culture at the local community level. And I think there are a lot of communities that fit this model. And that is where a few local people have a lot of influence and control over community related decisions. And they control those decisions in a way that's going to benefit them more than it's going to benefit the population. So that's why it's called elite capture. In BRAC's early experience, when they started community health programming, they recognized that they had become captive to elite capture. And so what they did, their whole entire program that reaches now 60 million people, what they have done, I don't know if this is necessarily the right decision everywhere, but in Bangladesh, what they did to avoid elite capture is they created a situation of forming women's groups called voluntary organizations. And not anyone could join a voluntary organization within the community. It was only the poorest women who owned no more than 1/10 of a hectare But if you had more land, then you could not join a voluntary organization, and that became the foundation by which BRAC expanded its program. So I think it's important to engage community leaders. There's no question about it. But I think we also need to keep in mind that we need to make sure that other people whose voices may not be so readily expressed and heard are involved in this. And of course, women and children are a great example of that, because community leaders tend to be men. But the care group process is one example of reaching every home and giving women in every home a chance to share their concerns is one way to avoid elite capture.
You have another hand raised if you want, or I can get you that.
Go ahead. Yeah.
Debola Lawal, you have your hand raised. You shouldn't need this. You have your mic.
Okay, we've been going for an hour, and this is a 2-hour session, and we're in the very early parts of the presentation. So it's been a great discussion. So let's take a couple of minutes break, and then we'll start in 2 or 3 minutes. I have quite a bit of material. We're going to go ahead and restart now. Thank you. Hope you've had a few minutes of break, and I'm going to pick up the pace a little bit. We had a very rich discussion on a very important topic, namely how to develop trust with the community and the issues involved in that. So that's the first step of CBIO, is establishing trust. But of course, program activities need to take place as trust is being established. And we all know that it takes time to build trust. And there's lots of reasons why communities may be suspicious and distrustful of health programs. I would say throughout the world, at the local level, there's enormous distrust, and particularly government health systems, for all kinds of reasons. And so building trust takes repeated activities that engender trust from the community. And of course, the program staff need to develop trust from the community that they're going to help out with what they need to do, and that takes time. So that was the first priority that I have listed as to be thinking about it. Now, we spend a lot of time talking about epidemiological priorities. So does anybody remember from yesterday what the definition of epidemiological priorities is? Would somebody like to chime in and tell us what the definition of epidemiological priorities? I'm giving you an exam on yesterday's work. So Nat, come up here. Nobody else is going to offer? And nobody's offered on chat? If you know, unmute yourself. it took Matt 30 years to learn this. So if you're just getting exposed to CBIO now and you haven't learned it, then you have an opportunity to learn later.
What are the most serious, frequent, preventable, or treatable conditions in a defined community?
That's perfect, almost. You missed one important word.
Readily.
Yeah, in fact, it's not in the article, but well, it is actually in one place, but in other places it's not. It's readily preventable or treatable conditions. So the most frequent, serious, readily preventable or treatable conditions in that community or set of communities. And the precise methodology for defining that isn't obvious, and it takes some expertise perhaps, but it also is something that the community needs to participate in. And Mario shared with us yesterday of how the community participated in the definition of what the epidemiological priorities are in the community. So that's one piece of a community diagnosis, is defining the epidemiological priorities. The other key element in a community diagnosis, as I said yesterday, is defining the community's own health priorities as they perceive them and understand them. They may be very different from the epidemiological priorities. And most commonly, in our experience, a community priority is expressed as a need for better curative care. We want a doctor, we want an ambulance, we want a hospital, all these kinds of things. But if you remember from Abhay Bang's speech yesterday, he had a list of what community priorities were. If you remember that, one of the community priorities that his communities came up with was alcoholism. That's a very interesting community priority, and it has many health effects, of course, but it's one example of a community priority. And in fact, in Gacharoli, as a result of that, they developed a very exciting and effective program directed towards the problem of alcoholism in their communities. And there's an article written about it that I happen to know about. So anyway, these are obviously important steps. But as you're trying to get a program started, you're thinking about all other kinds of things, and you may not give attention to that to the degree that it would be ideal to do. So then the next beginning step in CBIO is defining the baseline level of health in the community. So if you don't know what your baseline is, you have no way of knowing whether you've made any improvement in the health of a population. So collecting baseline information is essential, and it takes time and energy to do that. And it's very much like a doctor. I bring back again this whole idea of CBIO is a similar relationship between a program and a community to the relationship between a doctor and a patient, but on a more expanded level. So it's important, if a doctor is going to treat a sick patient, to make a diagnosis, and that may involve obtaining some tests, spending some money, doing some kind of evaluation on the patient. If the diagnosis that the doctor is going to make of the patient is going to be accurate, and that leads to a treatment, which hopefully has some scientific basis for it, that's going to create an improvement in the health of the sick patient. So the same analogy applies for CBIO, but on a larger scale. But there are many ways of thinking about health and defining health, as I've mentioned yesterday. And so we can think of health in terms of levels of mortality, which at the end of the day is, from my standpoint, the most important of the definitions of health, particularly in an environment where levels of mortality are much higher than what they should be. But we can also talk about the prevalence of serious illness that may be there, the prevalence of serious disability, but also, as I mentioned yesterday, I think it's important for us to know what the immunization coverage level is within the community, because it may not be seen as an important issue, but in fact, over time, maintaining high levels of immunization coverage is in fact very important. And also the level of utilization of family planning services, the contraceptive prevalence rate has many relationships to health, as well as economic well-being in the family and on and on. I mean, we've heard examples of that from yesterday. There's also the contraceptive prevalence rate is the percentage of women of reproductive age who are using a modern method of family planning. But there's also something called the unmet need for family planning, which is the percentage of women who do not want to bear a child in the next 2 years who are not using a method of family planning. So it's another example of an indicator that is important, I think, in defining baseline levels of health within the community. I'm stuck again. I don't know. There we go. Okay. Oh, comment or question?
Henry, could you go back to the last slide?
Come up here, Pat. So we're very happy to have Pat Taylor with us, who's a long-term employee of John Snow International and spent her career in global health work. So Pat, come stand here.
Okay. Thank you, Henry. I was just wondering, I'm not understanding whether this is sort of a linear process or you could do several of these things at once. So if I'm looking at the developing trust and trying to define the community's health priorities, could I do that at the same time? And the same thing with the epidemiological priorities and the baseline surveys or collection of data.
Great question. So in the paper, we speak to that issue. So theory and practice are closer in theory than practice. So I think it's in the reality of implementing these things, all this stuff is going on at the same time, essentially. But of course, collecting baseline levels of health is very important to do early on, because if you don't have a good baseline, then your assessment of whether or not you improved health is going to be faulty. And we have many examples in our own experience where we started a program without an accurate measure of the mortality rates in the population. And as I mentioned yesterday, it takes time to build an accurate vital events registration system for many reasons. And so we've had experience where in the beginning, the vital events registration showed a level of mortality, under 5 mortality, for example, that was rather low. We started the program, very effective program, and then as we continue to strengthen the vital events registration system, the mortality was going up, which was not in fact, at least we don't think it wasn't in fact taking place. What was in fact taking place was that we were capturing more deaths into our system than we had been capturing at the beginning. And so it's a very important technical issue. And the Bangs, for instance, in their work in Gacciaroli, before, if you noticed in his graph, they had a stable baseline level of infant and neonatal mortality for several years before they started their intervention. And then they were able to show that in the intervention area, after their baseline level, it started dropping, and in the comparison area, it stayed stable. So I think it's a terribly important technical issue. And related, I'll talk about this later as well, but the accuracy of vital events registration is a terribly important issue. I mean, I've already mentioned this a number of times now, but how we can build strong vital events registration systems that we can be confident are accurate is a terribly important issue. So Yambo, you wanted to make a comment, please come up.
It's a brief one, but I think it's worth mentioning because
So we're very happy to have Yambo Tonkara here, who is the Director of Community Health for Catholic Medical Mission Board. So welcome, Yambo.
Thank you, Henry, and thanks everyone for having me. I think talking about priorities, I just wanted to share a little bit experience from CMMB that we made the intentional separation between registering the problems and then defining the priorities. Because if you take a community like South Sudan, it's a lot of problems. Everything is a priority. So you have to make a priority of priorities. And so when you depend on what really kills people, sometimes that's not the problem. So in our experience, we got into a situation, a very interesting situation where it took us maybe half a day to debate between, is the priority, is the top problem HIV or nutrition? It was a fascinating conversation. So we have a similar approach as CBIO, but we found it interesting or important to distinguish between cataloging the problems first and then challenging the community and the participants to say, what's really the top priority?
Okay, well, I think that comment helps us to appreciate some of the complexity that goes into all of this, and it's not straightforward. And one of the comments in the article that's made is we need to think about the underlying causes as well as the immediate causes of death. And so there's enormous amounts of data that show that undernutrition is associated with, or you can even say, if you want to, the cause of half of all deaths of children around the world in low-income settings. And so to not give priority to nutrition is not addressing the underlying problem. So we need to think about what the underlying problems are, as well as the immediate final cause of a death, for example. So this is not a simple or an easy process. So we've spent a lot of time talking about building trust. It takes time, requires responding to community health priorities and development of personal relationships with community leaders, and routine systematic visitation is a powerful way to build trust and knowledge and awareness between the program and the community. So defining the community. So that's not a very simple process either, but in our view, you've got to define it. You've got to create a boundary somewhere of what your community is. Otherwise, you don't really have a handle on what you're trying to do, and you don't have a way to define whether you're making any improvement or not. And sometimes the boundaries of a community may not be that obvious, but it's got to be done. And so we have been involved with CBIO in developing a census and maps, and those are very time consuming, and you can't do it without strong collaboration with the community. And so I think Kevin was telling us earlier about how surprised he was with the eagerness of the community to participate in this work. And I think that's a general experience of many programs. So once a group comes in and expresses an interest in starting something like this, the community steps up and participates. And so I think it's important not to be too discouraged or too overwhelmed by the complexity of the task. And I'm going to share with you a little later, I think in a minute here, the experience of BRAC, where they were able to do this kind of thing for 8 million people. So I think everything that I have said here about routine systematic home visitation has been repeated already, but I think it's important to go over these basic ideas about routine systematic home visitation. So we've talked about building trust, but we also need to talk about how to engage the community in the program. And I just was talking about BRAC. I didn't realize it was the next slide here, but I had the privilege of working with one of my students at Hopkins who went out to BRAC in Bangladesh and helped them document the first steps that BRAC went through as they established their urban slum project called Minoshi in a population of 8 million people. And so we have an article that has been published about this. And these are the various steps that they went through in the starting of this project, which went massive scale to 8 million people in the urban slums of Bangladesh. I'm going to show you a video of this later. But you can see that they were involved in the formation of maternal and neonatal and child health committees, meeting with those committees, and that was the beginning step of building community engagement. And through that connection, they were able to start the census taking process and what they call social mapping, which was creating a map of the key geographic issues in the community and where key facilities were and so forth. Responding to community feedback, which helped to build trust, and then involving local resources as much as possible. And then the training of people who can do the mapping, the beginning of the mapping with working with key informants who can help with the mapping process at the local level, developing the list of households, information on the details of the family that came later after the mapping has been done. So this is an example of a community map that the BRAC program developed in a slum of 50,000 people. So they made these maps all over the country, and they had 8 million people involved in this. But it took community collaboration. You can see the level of detail of each of these little houses that have been placed on this map. Here's a map from Guatemala that our team worked with the communities to develop, and these are placed at a central place, a central location in the village where people can see them and comment on them. And this is called the Sala Situacional Jurisdicción Coya. So in addition to the map, there's a lot of information about the health statistics for that community, which the community helped to develop. So now a few words about the diagnosis, the community diagnosis, which is a combination of the epidemiological priorities and the priorities that the community has defined. So one of the principles of CBIO is that at the time of making a community diagnosis, we have the community's priorities and what the epidemiological priorities are, but over time that's going to change. But this is not going to happen the next day, but over a period of 3 to 5 to 7 years, the priorities are going to change, both the community priorities and the epidemiologic priorities. So in terms of defining what the community's health priorities are, there's no set standard of steps to do this. There are many ways to think about it. And I won't read everything that's on here, but you can see that. But as you remember from Abhay Bang's presentation yesterday, they actually had a vote. It looked like it was women who were voting. I don't know if they limited the voting to women or not, but it's a democratic way of thinking about establishing priorities, but it requires everybody coming to one place at one time to make a vote. So it may not be that simple to do, but I think it's important to consider a process for defining the local community's own priorities as they perceive them, and then incorporating that into your community diagnosis. So in terms of epidemiological priorities, we've mentioned all of this, but I think I'm kind of stuck on the issue of mortality assessment. I think it's so important, and it's so underrepresented in global health work, and there are many reasons for it. But I think at the bottom of it all is there's this basic idea that 99% of people have, which is that it only takes an outside expert with a lot of money and a big population to carry out a mortality assessment. And I would submit that that's a false presumption, and that in small populations, mortality rates can be calculated, and causes of death can be calculated, and it can be useful to guide program activities. So serious illness, that may or may not be a problem. There are many ways of thinking about serious illnesses. We're not talking about colds and coughs. We're talking about something that's relatively serious, like tuberculosis, for example. May not have an immediate mortality, but it does have a significant mortality on down the road as an important illness to be thinking about. And disabilities are virtually totally ignored in global health, as far as I can tell. Of course, you know, if you go out in the community, there are enormous numbers of people out there who have serious disabilities, whether it's mental retardation or club foot, cleft lip, some kind of psychiatric illness, which is disabling. I mean, there's an enormous burden of disease and ill health out there that's related to disabilities, and we're only now beginning to think about and documenting effective approaches that can be carried out at the community level to help disabled people become more functional. And it's a great pioneering area for community-based primary health care, but there's no way in most of these settings where we work where there are going to be higher level facilities that can do anything about these problems. I'm wondering if anybody has some thoughts from your own experience about the level of disability within communities and our inability to do anything about it. I think it's a terribly important issue. Mario? No? Anybody? If you're involved in, this is one of the early things that really hooked me on home visitation. If you're involved in going to every home, it's amazing the stuff that you'll bump into. I mean, I've been in homes where in the back room, there's somebody with a mental illness who's chained and nobody knows about it, and the family doesn't want anybody to know about it, for example. But surely somebody has some experience with this besides me. Nobody wants to raise their hand. Come on up, Pat. Nobody raised their hand.
Henry, you're talking about, I don't think the camera's on. You're talking about disabilities that are more like congenital or things that somebody's born with, but there are also lots of cases where malnourished children are actually kept in a back room and not brought out because it reflects badly on the mother and the culture, right? So I haven't seen a lot of work going on with disabilities. There are some countries that seem to do a better job of it than others, but it's still like the main kind of child health illnesses and things that cause mortality are still the focus in most places.
Yeah. I did not mean to convey that we're talking only about congenital problems, but for instance, as we saw yesterday, issues of poor eyesight, that's a disability. And there's a lot that can be done to ameliorate, to mitigate the issue of poor eyesight. And that's a whole complex topic in and of itself. Okay, so we have Dr. Stanley Blanco from Bolivia wants to make a comment. So we're very happy to have you, Stanley. So please go ahead and speak.
Good morning to every one of you. Can you hear me?
Yes, we can, very well.
Great. It is a very nice opportunity yesterday and today. All the discussions were very, very extremely important. Talking about disability, Dr. Perry, you were some weeks ago visiting Santiago de Ocola, which is a community very near Ancoraime, San Carabuco. And what we see there is that it is a community of 60 families.
Is making some adjustments. So anyway, go ahead. Sorry to interrupt you. Go ahead, Stanley. Did we lose you? You may be.
His microphone's unmuted, but he's not. We're not hearing him.
So somehow we've lost you, Stanley. Is maybe you muted something that should not have been muted. Looks like he dropped off. So when he rejoins, we'll try to get him back again.
We have a comment from Julia King.
Oh, we have a comment, Andrew. Now we're getting him muted.
About disabilities, and then she has a question as well.
Julia King from CMMB says that she works with children with disabilities in Peru and Zambia, identifying children during household visits and providing therapeutic care, as well as community awareness and caregiver support. This care can be very intensive and costly, as therapies and support to cases lasts for years. She also has a question about how to carry out mortality assessment in very low populations where reaching statistical significance presents a problem.
Okay, so we'll move later into issues of accurate measurement of mortality. So, but it's great to hear that CMMB has a program specifically directed at disabled children. Our program in Montero has a separate program for disabled children there, and it's funded through a separate mechanism that comes directly to Montero, and it's expensive. So it's just one of those things that has to be brought into the equation and discussed about how we can best use the resources available, and in particular, how to use local resources that are not financial to help address issues of disability. And there's a lot of stigma that's associated with disabilities as well. And so overcoming stigma, there are NGOs that are involved with helping communities overcome stigma that can help bring people with disabilities more into the mainstream. Nutritional status in children, immunization coverage, and contraceptive prevalence, we've mentioned again, should be part of thinking about baseline levels to help you determine what your epidemiological priorities are. So I think all of this is somewhat repetitive, but there's so much power involved in collecting births and deaths from routine prospective household visitation. Most mortality assessments that are done around the world are so-called retrospective surveys in which somebody goes to a household and asked over a period of time in the past who died, who was it, what age they died, et cetera, et cetera. And the demographic and health surveys, which are carried out all over the world, which are kind of the gold standard for this, they're retrospective surveys, but they involve an outsider, usually a college student, coming into a community and visiting a home, a sample of homes, And so there are people who question whether or not somebody like that could get really highly accurate information by visiting a home with an interviewer who's never been to that home before. It's a question that's interesting, and I've never seen any empirical confirmation about whether or not that's true, but it is an issue to think about. And if you have a system in which some local person is visiting a home on a regular basis, whether it's once a month or what it is, they're much more likely to pick up and obtain information about a death and a birth that took place, and they're also more likely to be able to determine whether or not it was a stillbirth or a live birth, which is another important issue related to the quality of vital events registration. If you're collecting data through a retrospective survey to measure mortality, it requires very high household samples to do that, because a death is a relatively uncommon event. So that's an issue which we don't have time to talk about at length, but it does require a sophisticated approach and high sample size, much higher than you would need if you're visiting every home. But household surveys are a good way to measure the nutritional status in a population, the immunization coverage and family planning coverage. Those can be done relatively easy with a small sample of households within a population. That's a much easier thing to do than the vital events registration of deaths particularly. So we're talking about measuring mortality rates, or in the case of maternal mortality, we talk about ratios, the ratio of maternal deaths to live births, nutritional status, levels of disability, serious morbidity, immunization status, unmet need for family planning. I mean, these are all not easy things to measure, and scientific research projects spend millions of dollars doing all this. So the question is, how can we apply these techniques with relatively low-level staffs and relatively small populations of 50, 100,000 people or 150,000, district level kinds of things? It's a very important question, and I think we can spend a lot of time considering how we can help ministries of health at the district level carry out these kinds of assessments, which I think can be very empowering for local programs, but I'm not aware of any experience where this has really been tried out, and I'd like to be a part of doing something like that, but I haven't been able to yet. And of course, the other value of household surveys is assessing the level of household knowledge and behaviors that are important for activities that are influential in keeping people healthy or causing mortality. So immunization programs were the first example back in the 70s and 80s where household surveys were taking place, in which it was important to measure the level of immunization coverage within a population. And so all the methodologies for household surveys, at least in global health, were really developed at that time, and the cluster sample survey became the standard for sampling households for determining immunization coverage, and then that got extended to other various things like we're talking about right now. We don't have time to get into all the details of this, but a cluster sample survey is attractive because it enables you to survey a much larger population with less staff than would be required if you were doing a simple random sample of households. So if you think about a national survey for measuring the immunization coverage in a population, you can select let's see, I'm having a senior moment here. you can select 210 households in your total sample size, but you only need to go to 30 places to measure those 210 households. So if you have a country that you're going to, you only have to go to 30 places, as opposed to if you have a simple random sample, which is not a cluster, you'd have to go to 96 places. So if you're talking about sampling a large geographic area, a cluster sample survey is a much more efficient way to do it. You randomly select a household, and then once you go to that randomly selected household, you interview a cluster of people, either 7 people or it's more now, it's 10 people. So you go to that one place and then you interview 10 people around that randomly selected household. So that's the standard cluster sample survey. It has become very popular, this idea of LQAS, which I'm not going to go into now, but a lot of people know about it, but it's lot quality assurance sampling, and it's got a sophisticated method for determining which lots in a population, which means a geographic area, is underperforming. But in actuality, the LQAS sampling requires an independent selection of each household. And if you're working in a relatively small area, that's not really problematic to have independent sampling of every household. If you're working in a peri-urban area, for example, where the whole area is not that big, but the important thing about simple random sampling, which is what LQAS involves, you only need 96 respondents to have to measure something with a confidence interval of plus or minus 10%. You only need 96. If you're doing a cluster sample survey, you need 210 or 300 respondents, something like that. So if it's a relatively small program area, then simple random sampling can make it relatively easy to have an accurate level of an indicator. You couldn't do it for mortality because it takes a larger sample size, but for immunization coverage or contraceptive prevalence and behaviors, you can do that. There's a very interesting idea that World Relief, which is an NGO that's had very outstanding community health programs, they developed this. And I've always wanted to write an article about it or help them write an article about it, but they call it a mini KPC, MINI. And this is a KPC, knowledge, practice, and coverage survey, in which the collection of the survey information is built into the daily activities of the supervisor of a care group or the leader of a care group. And so and this was for programs of care groups. So in a care group program, you know exactly where each household is. And the promoter, the facilitator who meets with the care group, that person is going out to where those people are every month to meet with the care group. And so it's possible, very simple to do actually, within the program itself, to create a random list of households to be surveyed at the time the promoter goes out to that area over a 3-month period. And so as the promoter goes out there, then she receives an instruction. While she's out there, she's going to go to this house and ask this small set of questions. So the reason it's called the mini KPC is that the way this was developed, each time they do this every quarter, the promoter facilitator only asks a small set of questions, maybe 3 or 4 questions about one indicator, immunization coverage, for example. And every quarter they're doing that. It's built into the ongoing work of the program. It's not a separate activity where everything else stops and they do the household coverage KPC. It's just built into the routine work of the promoter facilitator, the paid staff person who meets with the care group. And I'm going to show you some examples of that in a minute. Well, this is an example right here. So this is from a project in Cambodia that I was privileged to serve as an external evaluator on. And you can see here, this is hand washing practices. So most of the dots on this line were measured with a mini KPC. So basically the key indicators were being measured every quarter, but only one indicator was being measured during a quarter. The next indicator, the next quarter, another indicator was measured. And so in essence, what this meant was that once a year, they had an indicator about hand washing. And similarly for immunization coverage and other things, but they also had a baseline and an inline KPC that was a full cluster sample survey that was the full thing. And so you can see here that between the baseline and the inline, and I think there was a midline KPC as well in here, but you can see that the results from the mini KPC were consistent with the trends that were confirmed with the more intermittent full-blown KPC survey. But the other important thing is how rapidly the coverage of this indicator rose, and care groups are famous for being able to achieve rapid expansion of coverage of key child survival interventions. So here's the one that was developed for immunization coverage. So again, you see how quickly it rose, but also how the mini KPC results fit very nicely with the overall trends that were measured by the KPC survey. So we've talked about family health folders yesterday, if you remember, and I think they're terribly important for the operation of a census-based program. And this is an example from one of our programs in Bolivia. And as we mentioned yesterday, a family health folder contains the health-related information for a family, and it's recorded and stored by the household number in the community that the family lives in. So it makes it very, and the families know their household number, and it makes it very easy to store this, but also as the community work takes place, they can sometimes they actually take these folders out into the community, or sometimes they have some shortened version of it. But this is the case in Bolivia, and I've been to several health posts in Ethiopia. This is from Ethiopia, and so they have the exact same system that we had in Karabuko in the early 1980s, but this is for 150 million people. So a little bit more about mortality. Obviously, there's a lot of technical angles on this that we can't go into now, and I'm not a complete expert on this, but I have spent a lot of time trying to understand and have thought about it quite a bit. I showed this yesterday, but this is an example of data that we were able to produce from a population of about 10,000 people. And it's based on data for 1 year. So it's an example of a mortality assessment in a small geographic area, but it still provides very impressive findings in terms of helping communities understand what their priorities should be in reducing mortality in their area. And of course, you know, when you get to be 75, there's not too much you can do to reduce mortality among old people, but look at all the things we know that can be done to reduce mortality among newborns and children in their first year of life. This is the same mortality profile, but in Cochabamba, which is a tropical lowland area. And here you see in the second year of life, from age 12 to 23 months of age, we see a mortality level that's virtually the same as during the first year of life. And the reason for that is because at that time in Montero, there was a large number of deaths from diarrhea and malnutrition, which really kicked in at 6 months of age up to 18 or 24 months of age. And that was a very serious problem in Montero. And that led our project to put a lot of energy into improving the water sources within the community. Our leader, Dardo Chavez, whom you met yesterday, he got involved with creating community water systems with the local government. And also that led to the project's involvement with the Centers for Disease Control in Atlanta to carry out the first field test of something called point of use water systems. So I'm sure some of you have heard of that, but maybe not all of you. But a point of use water system is one in which water is collected, and at the household level, it's put into a container that has a very small cap to it. And then within that container, some chlorine is added to reduce to a very high degree the bacteria and viruses that are in that water. And it's become a standard of improving the water source for very poor people all over the world. And our project in Montero was the first field test of the effectiveness of that approach, and it's been published, and Dardo Chavez is the co-author on that paper. So it's to me, something that I'm very proud of that we helped to facilitate, and it was through Dardo's leadership and his connection to the community and the identification that we had of how important diarrhea was as a mortality priority, an epidemiological priority, that this all came about. So I showed this yesterday, but this is another graph that shows the importance of diarrhea in Montero, which is the high bar that you see for diarrhea, and also the high level of malnutrition over to the right in Montero relative to the other program areas. So here's another interesting finding from our work in Kirabuco. This is an analysis of all the deaths that were registered over a 6-year period in a population of 10,000 people. And you can see here, if you just add up all the deaths, irrespective of the age at death, the most number of deaths were due to old age, which is understandable. But look at the second most important cause of death, injuries. So that became an epidemiological priority. Our program in Kirabuco never was able to get around to addressing other epidemiological priorities because we were focused on child mortality and maternal mortality. But we could have done more with this if we were more focused and had a better source of funding and so forth, but we didn't have it. But injuries and accidents were very important. So then if you look among injuries and accidents at what types of injuries and accidents were taking place within this one population of 10,000 people, you can see that poisonings and suicides were the leading cause of injuries. And we came to find out that poisonings were generally self-inflicted, almost always. People had access to insecticides for their potato crops and for spraying their plants so that they would be healthy. And they also came to learn that they could kill themselves with this insecticide as well. And so, and there were other kinds of suicides as well that were unrelated to poisoning. But, we never were able to develop a program for this, but if you follow the logic, we certainly could have and perhaps should have if we were true to our methodology. So this is going back to Cambodia, where I had a wonderful experience now a long time ago, but still, you can see here, this is another example of data that were analyzed through vital events registration that were collected by care group volunteers going home to home, and then the care group volunteers reported them to the care group facilitator who wrote it down, because virtually all of these care group volunteers were illiterate. So they reported it to the care group supervisor who wrote it down, passed the information up the system, and then this information was collected and then analyzed. And so you can see that in this case, there were few there were few deaths among children who are more than 1 year of age, right? So, I mean, to me, that's a very important finding, because if you're interested in reducing mortality within the population, you don't really need to pay much attention to children who are more than 12 months of age. Here is looking at the cause of death among neonates in Cambodia. And you see here that most of this is due to prematurity. There's still some neonatal tetanus, which is a readily preventable condition by immunization, of course. Pneumonia, but prematurity was the leading cause of identifiable mortality. And, you know, addressing prematurity is not a simple thing. I don't have time to go into that now. But among children 1 to 11 months of age, you have pneumonia as the far and away the leading cause of death in this age group, and then a variety of other causes as well. One of the things we found when I worked at the Hospital Albert Schweitzer was that there was an important geographic determinant of mortality in that population. It took a while to find this out, and it's not that easy to come up with the information that can verify something like this. But the Hospital Albert Schweitzer had a coverage area of about 300,000 people, and about 2/3 of them lived in the valleys, and 1/3 of them lived up in the mountains, which were much more isolated. And what we found was the mortality among children in the mountains was twice as high as the mortality of children in the plains. And so that I was the director of the Hospital Albert Schweitzer, and I knew all this, but unfortunately, I couldn't do too much about it. But the logic of this is that if we're really serious about reducing the mortality of children in this coverage area, we wrote an article about this, we need to give more energy and resources and attention to the service delivery in the mountains than in the plains. And the people in the mountains were less educated, poor, living in more isolated communities and households, and that takes more energy to address those. And we had a community health worker program that was designed in such a way that every household in the whole population received a similar level of service. But in fact, if we were really serious about applying this information, we should have had a more intensive. The other problem was that the community health workers in the mountains, they may have had the same number of households, but the households were further apart and they had to walk up and down mountains. And so the reality was a much tougher job for the same number of households than the community health workers in the plains were facing. So it raises a number of interesting issues about program implementation. So here are a few examples from Guatemala. This is, and by the way, this is data that we just published in February based on our 5-year child survival project that we carried out from 2001 to 2015. We published it in 2023, but the principles and ideas are certainly still valid. So the bottom set of graphs is the age of death during the first 5 years of life. So you can see it, 57 is the bottom number there. So the last dot is 60 months. So this shows the number of deaths by age at death, very simple. And you can see the concentration of deaths that take place during the first month of life. See that? A much smaller number at age second month of life and the third month of life, and then it drops down to much smaller numbers, right? So this is a high priority group, the first 3 months of life, but particularly the first month of life. Everybody see that? So then if you go to the graph at the top, this is the age at death among neonates. So look at that. The first, the great proportion of the deaths among neonates take place during the first 24 hours of birth, right? And you can even extend this one step further and look in the first 24 hours of life, the number of deaths that take place by each hour. And we didn't do this with these data, but I've seen published data where most of those deaths take place in the first 6 hours of life. So this is very important information for programming if we're interested in reducing mortality. Then we have in Guatemala, the causes of death. So among neonates at the top, we can see that what's called birth asphyxia or intrapartum complications was the most important cause of death among neonates. So these are pregnancy or delivery related complications, and it's one reason why having a birth that's attended by qualified people with training is so important to help prevent intrapartum complications, which have led to these kinds of births. And you know, a lot of these are children who are born not breathing, but if they're properly resuscitated, they can be brought back to life. But so it's and this is what the Bangs have been able to do by training community health workers to address these issues. But the other important thing is among children 1 to 59 months of age, pneumonia was far and away the leading cause of death. And diarrhea was a smaller proportion, but pneumonia was far and away so important. So having a program that can identify children with signs and symptoms of pneumonia and getting them the most effective treatment that we know scientifically is a program priority. We had a lot of problems in Bolivia because our community people could not treat these because of the policies of the government. So that's a whole nother set of issues. So here we're talking about maternal deaths. And we can see here that from Guatemala, among the maternal deaths that we registered over this 4-year period of time, 62% of them took place in the home. 26% were en route to the hospital, and those were home births that had a complication that were taken to the hospital, but the mother died en route, and only 12% died at a health facility. Here's an example from our KECOP project showing the early measurement that they had of maternal mortality and how they were able to bring that down. No, sorry, this is all baseline, excuse me. This is all baseline levels of mortality. And Kevin has mentioned this several times when he was up here talking, but it shows that they were able to identify early on, and KECOP is an exception to this because somehow they were able to apparently register a high percentage of the deaths that were actually taking place. And I don't know how you did that, Kevin, but maybe you can share that with us. But you can see here that they were measuring in the blue column a maternal mortality ratio that was more or less 1,500 maternal deaths per 1,000 live births. Now, this is in a relatively small population of people. So it has a confidence interval around it, which is sizable. And we can talk about that issue a little bit later. I'll get into that. But you can see, as he said, and this is, so the blue one was in one of their program sites. The orange one was in a second site. And the gray one was in a third site of their program. But you can see how much higher those mortality rates are than what was being reported for Kisii County, which is the area of Kenya where their project's located, and compared to the national average. So it's, again, an example of pointing to the need to address maternal mortality in their local program area using local data. I'm now realizing it's after 11 o'clock, so it's time for our break. Let me mention one other thing which is terribly important as we get involved with longer term programming of this, and that's the importance of community re-diagnosis. Our work in Montero, we're very proud of. You saw Dardo Chavez and Mitma Chavez speak yesterday. The blue line that you see on the graph is the under 5 mortality rate in their program area of 30,000 people. It's not a large population area, but going back to 1992, you can see that they were starting with an infant under 5 mortality rate of 110, which means that 11% of the children were dying before reaching age of 5. And slowly over a long period of time, going back until about 2006, so that would be 15 years, I guess, something like that, they were able to get an under 5 mortality rate that is in fact lower than what exists within the United States. These other lines are comparison areas that came from demographic and health surveys. But, so obviously now under 5 mortality is not an epidemiological priority, right? I mean, what else can they do to get an under 5 mortality level that's lower than what they have? It's virtually impossible. So it's no longer an epidemiological priority. And they haven't had any maternal deaths there for a number of years now, and they're very rare, and their maternal mortality ratio is similar to that in the United States. So maternal and child health is no longer an epidemiological priority. This is the summary of the cause of death from Montero from 2018 to 2022. So what you see here is that aside from COVID, which occurred during this period, high blood pressure was the leading cause of death. To me, this was a very important finding, and the need represents the need for why we need to carry out a re-diagnosis of the epidemiological priorities. But there's also a need to carry out a re-diagnosis of the community's priorities too. So once we determine as best we can from the data we have what the community's priorities are and what the epidemiological priorities are, then through some mysterious process, working in collaboration with the community, we define a small number of program priorities, which is some combination of community's priorities and the epidemiological priorities. That's the theory. And then once we assess what the resources that we have that are available, then based on that and the community's priorities, we develop a work plan. Very simple conceptually, but the practice is another thing. Theory and practice are more closely related in theory than in practice. So, you know, program implementation, that's where all the work takes place. And we're not going to really speak to that because it's so dependent on the previous steps. But that's where, you know, 95% of all the effort goes in. But the work beforehand is terribly important if you're going to have an effective program. But the work plan and the implementation does need to be modified depending on what happens. And so then we're left with the issue to assess in a later point in time, did we improve the health of the population of people that we served? So I've been involved in this business for a long time now, almost 50 years, and there are very few examples of programs where they seriously address this issue more than simply measuring coverage of key indicators. And so I think CBIO is pioneering in the sense that we're trying to move beyond just measuring the coverage of key child survival interventions or key maternal health interventions, but really answer the question, do we really improve the health of people with real data in that local population? So I think maybe I better quit here because we run over time a little bit, and I'll come back to where we left off here, which gets into the issue of mortality assessment. So let's take a 15-minute break now, And then I'll come back and finish this up quickly, and then we're going to break up into small groups for discussion. Thank you. So we'll take a break now. Important principles about measuring work. So we're going to pick up from where we were before the break, and I want to mention some very important issues about mortality measurement. And you can see on this slide here that we need to be aware that just because the mortality is declining in your program area doesn't necessarily mean that the program was the cause of the mortality decline. As you saw here, in the case of Bolivia, there was ongoing decline in mortality at the national level and the peri-urban area and so forth. But we have evidence that the decline was faster in the program area than was taking place nationally or in the urban part of Bolivia. So it doesn't prove that the program was the cause of the mortality decline, but it's consistent with all that we know about the services and programs of Montero. But and so it's not possible to do randomized controlled trials. Am I being heard?
It's a little soft. You might mind using that microphone.
So, is that better?
Yeah.
Okay. So just because you can demonstrate a mortality decline doesn't necessarily mean that the program was responsible for it. But on the other hand, if you're having a dramatic decline, as you have seen and I'll show in other cases, it's hard to imagine any other factor responsible other than the program. So there's questions, and the critics and the scientists will say you haven't really proved your case, but it's somewhat analogous to the issue of the scientific issue of determining whether smoking causes lung cancer or not. There's never been a randomized controlled trial in which people were assigned to smoking and non-smoking that demonstrated that smoking was the cause of lung cancer. It's an association, but the evidence is so overwhelming that it's accepted now that smoking is the cause of lung cancer. So that's a kind of a dramatic example, but it's still, the issue is the same from a scientific standpoint. But as I mentioned here, plausibility is enhanced by measuring outputs, changes in coverage indicators, and comparing outcomes in a comparison area. If you can't measure outcomes in a comparison area, the least you can do is document the services you provided and the improvement of coverage of key services or key indicators that are consistent with the mortality reduction you were able to achieve, which is what we were able to do with our first mortality impact paper that we published from the Altiplano. So I'm going to skip over this. You can read this very quickly here. So we're talking about the ideal, and the application of the ideal is not always so easy with the capabilities you have as a program. So one of the things I like about CBIO is it's a set of principles that can guide your work, but you have to adapt it to the reality of your local program, what you can do. But without this set of principles, you're lost. Well, at least I think you're lost. Maybe you don't think you're lost, but I do. So we have this issue of distinguishing stillbirths from live births. And this is a very important issue for measuring rates because infant mortality rates are based on births of live born children. And so the staff need to understand the difference between a stillbirth and a live birth. And a live birth is a birth that occurs to a child that moves, breathes, moves or breathes after birth. What's the third one? Having another senior moment. If there's movement and breathing, either one after birth, even though it may die 30 seconds later, it's a live birth. And so that distinction in the mind of a mother or the family, they may not see the value of distinguishing that, but in terms of statistics, it's terribly important. So again, here are some of the finer points of all of this that are terribly important. So I've been through all this already as well. And we've never, in our experience at Cure Americas, we've never tried to document levels of disability or even serious illness, but it's certainly something that needs to be thought about, and we need to have examples where this has taken place, but we don't have any experience with it. And then this is just some basics related to household surveys that are important to think about. So the conclusion of all this is that CBIO implementation is complex, requires several years to implement effectively, requires a dedicated staff and strong program leadership. That's embedded in all that we're talking about here. But I've also seen many examples that confirm the next statement. CBIO is also highly motivating and gratifying for all who participate in it, staff and community members. So I'm going to stop here and not ask for comments or questions because it's going to be embedded in our next activity. So we're going to break up into small groups now. And you're going to have, once we get into the small groups, you're going to have 30 minutes to discuss one question, which is on the chat box, I think, but we don't, I'll type it on the screen here for the people who are in the room. But the question is, how can CBIO become an approach that is more widely utilized? That's the question. So in each small group, you're going to have roughly 10 people, right? And so you're going to be assigned to a small group for those of you who are online. And in each group, you'll need somebody to take notes, and you need somebody who's going to report back to the full group at the end of the 30 minutes. So you need to take a few minutes to introduce yourselves, because in the virtual small groups, you probably don't know any of the people in your other group, although you may know one person or something, who knows. So you need to take a couple of minutes to get acquainted, and then I want you to discuss this question. And after 30 minutes, we're going to reconvene back into the full plenary session, and we're going to want the reporter from each group to share the findings that came out of your discussion. Is that clear? Clear enough? Pat, you have a question?
Can you, Andrew, can you show the chat box so we don't all have to?
I'm going to type the question up on the screen here for the people in the room, so you don't have to depend on that. Okay, are we all set? I hope we're all set to break up into small groups. So
online, they're going. They're working on it.
Okay, very good. Can you mute me? I think we can break up into two groups. Plenary session now?
Yes. Yes.
So we're back in plenary session. I hope everybody had a fruitful discussion. What we want to do now is we want to have a report from each small group, and we're going to keep track of the key ideas that come out of this. Pat Taylor has kindly agreed to, under some coercion, to write down the key points. And of course, there'll be more than you can write down, so just focus on the main ideas. So why don't we start with the two groups in the room here that met. And so I think Kevin Cayando was going to report for your group. So Kevin, come on up.
Thank you so much. In our group, first of all, there was a heated discussion on the threshold, the CBIO threshold. But we were able to come up with points on how to be more widely utilized. One point that was very clear that CBIO work needs to be publicized. A lot that has been publicized is what has been implemented. Governments all over the world have want scientifically sound evidence before rolling out or adoption of methodologies. And so a lot of scientific work on CBIO and publications will help this to work. Another aspect, and specifically in the context of Kenya, was that involvement of local municipalities, local county governments is very important, because for sustainability, they are the owners of funds, they are the owners of the system, and involving them and getting buy-in from them will enhance adoption of CBIO in local contexts. Another aspect that was very clear, and this has been demonstrated by what Cure Americas is currently doing, is what we call exchange learning visits. Exchange learning visitations are very important. And for example, the Kenya team went to Guatemala, and this provided a platform and a blueprint for them to properly implement CBIO in Kenya. A lot has been done. Travels have been done from Bolivia to Bangladesh, Guatemala to Bolivia. And so these exchange learning visitations, even online learning visitation and online learning platforms, are helping to create and replicate successes and find ways of mitigation of challenges jointly between partners. Another one is the challenge in CBIO that most organizations are facing is high volume data. It becomes so tiresome and cumbersome for organizations to implement CBIO if they know the volume of data that they are able to, that they are supposed to handle. And so digitization of CBIO data will reverse this negative paradigm when it comes to manual data collection. And so it will make it easier for organizations and many partners to be able to implement CBIO. Another aspect that has been clear in our group was aligning to government goals. CBIO needs to align to government goals. If a government has a policy, let's say on universal health coverage, how can CBIO align itself to that? If a government priorities are on malaria, how can CBIO align itself to that? If a county government priority is on HIV/AIDS, how can it align itself to that? This alignment aspect will enhance the quick adoption of this CBIO approach. Better mentorship and having a lot of local champions. How are we able to bring more people on board to be champions of CBIO, not only us within this meeting, not only us having the attending the meeting online. We should find modalities of having more CBIO champions, those who can testify, document, and be able to tell the CBIO story to the world. Another aspect that is very clear is training of government officials on CBIO, because governments in the world are what communities are able to entrust themselves to. Most communities entrust governments, and training more of government officials will more or less create more buy-in among the government officials, and probably invest and fund CBIO. Another aspect that has been properly documented in our group is that CBIO needs to be a holistic approach, not only from the top government officials. How are we able to involve the communities to make decisions under the CBIO aspect? And how will this decision go bottom up in a way that will be documented again and be able to show people and showcase the world about CBIO? Data sharing was also an aspect in our group. And this data sharing will be able to document CBIO impact. People will be able to assess CBIO impact, and it will be able to be adopted by a majority of people who are able to see the impact that CBIO has. That's what I have to say, unless anyone from our group has anything to add. Anyone from my group having anything to add?
Walking the talk.
Walk the talk.
Thank you.
Okay. That was terrific. Congratulations on very excellent work by your group. So who's reporting from our Spanish-speaking group? Dr. Ramiro Yankee, the country director for Cure Americas Global in Bolivia.
Well, there were some common things, but I'm going to highlight the findings or the conversation in three main important aspects we want to suggest. One is adaptation. We were thinking that we really need to think about trying to combine what we find out in our communities, the epidemiographic priorities, with other priorities, institutional priorities that perhaps the Ministry of Health, the different municipal governments or different levels of the government has, or even the donors. So how to combine what we find out and what other priorities of other donors or institutions have. For example, about combining not only most treatable and preventable causes, for example, thinking about chronic diseases. Yes. The other group of ideas is how to make our methodology more efficient. We were thinking about how to, for example, do the home visits more efficient, trying to focus our attention in the or give more emphasis in people with major risks or priorities. Perhaps thinking about increase the frequency of the home visits, because one of the major issues of the governments are that the cost of the methodology is very high. We were also thinking about including technology, as the other group was saying, how to, for example, create the maps or home visits using the technology like tablets. There's a pilot in Kenya going on right now with KPC studies and perhaps in the future viral events. And the third group of ideas were how to advocate the CBIO. And in this case, we were thinking about increasing efforts to disseminate the results, outcomes that we are having, not only thinking about statistical data, but also qualitative data that we really need to share. We were happy that we are going to have very soon the website of the CBIO in which we can share outcomes, results, and even the tools, which is very important. We were also thinking about how to involve not only in the implementation or the planning, how to think about how to involve community leaders, not only to participate, but also they can show the results of the CBIO as if it were something that the municipal government or the Ministry of Health has reached, something that perhaps can be on. And this can increase what we call the political capital of the CBIO. And finally, we were also thinking about, especially in Bolivia, how to create in every country demonstrating areas in which we can show the activity, the CBIO in action, that people can come and show how the methodology is being implemented.
Okay. Okay, that was terrific. Thank you very much, Ramiro. So now we're going to hear from our groups who are virtually brought together, and I'm wondering if we could hear from our French-speaking group first. We have one French-speaking group, I think. Is that correct? So I don't know whether the reporter for the French-speaking group can speak in English. Is that possible? Who is reporting from the French-speaking group? You can unmute yourself and start speaking.
And I think they can still speak in French. We would just be listening on the English channel.
Okay, but I don't think we
can't hear.
Yeah.
Oh, I see.
If somebody in this room can translate for all of us who speaks French. So who's reporting from the French-speaking group? Do we have a reporter from the French-speaking group? Or should we go with another group? We did have a French-speaking group, right? Well, they can report in a minute. So who is reporting from another group that was convened virtually?
Danilo Rodriguez from Spanish-speaking group.
Okay, so we have a Spanish-speaking group. Danilo Rodriguez, where are you? Speak up. I think we're getting an echo, Danilo. Is there more than one microphone in your room?
Good morning. I am here very happy. Hi, my guys here. Hi, Henry.
Hello, Danilo. Welcome. Bienvenidos.
Okay, thank you.
Danilo, we will come back to you. Can we have a report from another group, please? We'll come back to you, Danilo.
It looks like he's ready now.
Okay, Danilo, go ahead. You can speak in Spanish. Usted puede hablar en castellano si quiere.
Ok, muy buenos días.
Buenos días.
Gusto de saludarlos. Hola Henry, mucho gusto.
Mucho gusto.
Espero estés bien. Nosotros hemos tenido la oportunidad de poder implementar la estrategia desde el punto de vista oficial o gubernamental, ¿verdad? Tal vez no la hemos implementado en la parte en un 100%, pero por lo menos hemos agarrado lo principal de la idea, que es prácticamente llevar la atención a las comunidades más postergadas. Nos hace falta un poco, sobre todo en el tema de capacitación y en el tema de asesoría y en el tema de acompañamiento en cuanto a las metodologías comunitarias. Hablemos CBIO o hablemos otro tipo de metodología. Y en eso es donde estamos trabajando ahorita, ¿verdad? Nuestra meta es que el programa, o de hecho es si la estrategia sea sostenible y que sean fondos gubernamentales los que estén destinados para poder trabajar directamente con las comunidades más postergadas. De hecho, estamos ahorita analizando la manera de poder trabajar ya prácticamente aperturar otras 2 centros de atención intercultural del parque para poder trabajarlo. Entonces, yo creo que esto sería la participación mía, ¿verdad? Para poder seguir incidiendo en la parte de la atención de los nacimientos a nivel comunitario, ¿verdad? Y sí, en determinado momento hemos visto la necesidad de poder implementar por completo la metodología.
Someone help me with that?
Danilo, we were having trouble understanding the key messages there. No podíamos entender bien los mensajes que usted estaba diciendo. ¿Se puede tratar de resumir un poco más brevemente exactamente los temas críticos de sus palabras? Ya. Y otra pregunta es si usted está reportando para su grupo o es una opinión de usted solamente.
Estaba reportando en el grupo con Andrés, sí.
Ok. ¿Se puede repetir un poco más brevemente las ideas principales?
Quiere que bueno, lo que queremos es...
¿Se puede repetir otra vez los temas principales porque no pudimos entender bien qué estaba diciendo?
¿Me escucha ahora bien? ¿Sí?
Sí.
Ok. El tema principal es asegurar la sostenibilidad de la estrategia de casas de atención intercultural del parto. ¿Ahí estamos?
Somebody understand that?
Sustainability of the casas maternas.
La sostenibilidad de las casas maternas.
Eso con fondos del mismo Ministerio de Salud, pago de personal, insumos, que es lo que nosotros estamos abogando hasta el momento, más la infraestructura, que es una infraestructura de tipo comunitario y con inversión de las municipalidades.
Ok. Muy bien. ¿Otro?
Sí, y luego poder llevar la estrategia a los lugares más alejados, más postergados.
Ok. Gracias.
Y luego, por último, por lo menos nosotros le cambiamos el nombre porque habíamos tenido un poquito de problema al mencionarlo como casas maternas.
No podemos escucharle ahora.
Ahora sí.
Ahora sí.
Bueno.
Sí.
Nosotros le estamos cambiando de nombre. Le llamamos Centro de Atención Inter.
Ok, bien, gracias. ¿Hay más?
Nosotros desarrollamos la estrategia a la mitad porque nos cuesta un poquito trabajar la parte de las metodologías comunitarias, porque si nosotros le pudiéramos dar ese auge de metodologías comunitarias, yo creo que estaríamos al 100% trabajando la estrategia. Entonces, acá nos hemos quedado cortos en los procesos de capacitación y acompañamiento, ¿verdad? Para poder, digamos, implementar la metodología al 100%, que eso sería lo que nos haría falta, ¿verdad? Y digamos, en este caso, pues tendríamos que buscar los mecanismos para poder implementar este tipo digamos, de capacitaciones y acompañamiento con gente que ya la ha implementado y que tenga experiencia. Ahí estamos.
Ok, muchas gracias. Gracias para su grupo. Su grupo fue de Guatemala totalmente, ¿no? Ok, estamos contentos de saber que teníamos un grupo de Guatemala. Gracias. Okay, so let's hear from another group. We have an online English group, we know, so where are you? Can
Harriet
you?
is raising her hand.
Harriet Napier is raising her hand. So Harriet, go ahead. You're muted, I think.
Yep, sorry, I was having trouble unmuting myself. Thank you, thanks. So I can share a couple takeaways from our group, but I would also ask if others from the group have things that they would like to add to please do so. So one interesting takeaway that that I had from our group is that there are many different stakeholders that can and should be engaged to promote wider use or uptake of CBIO. So examples include, of course, the government, Central Ministry of Health, implementing and technical partners, and then also donors. So we discussed how each may require a different type of sensitization to the benefits of CBIO, and their interest or concerns may also vary kind of across the different 6 principles. We also discussed strategies for uptake of CBIO across vertical disease programs. This was one of my questions to the group coming from a malaria program, and how community health workers can really serve as a key platform for integrating, what can be are often fragmented efforts. So thinking about community structures as really the.
So Harriet, you're coming in and out. So can you talk a little more slowly and a little more loudly, please? I think that would help. And Pat Taylor asked if you could go back to the previous point because she didn't quite get it.
Yes, absolutely. Okay, I will speak more slowly. So the first point that I wanted to share was on different stakeholders maybe require.
Yeah, go to the second point. We got that.
Okay, the second point was the one that I was just going into now. So the second point was on strategies for uptake of CBIO across vertical disease programs and how community health workers can really serve as a key platform for integrating what are often fragmented efforts by different disease programs. Finally, the third piece that I wanted to share from our group was World Renew shared about their experiences using the care group model in different settings as really a helpful starting point from an implementation perspective. So thinking about kind of what are the structures that can be engaged to increase uptake of CBIO principles from an implementation perspective, looking at community health workers and care group models as sort of readily available partners, collaborators, platforms for wider uptake of CBIO. I'm not sure if others from the group have other pieces that they would like to highlight. Thank you.
We're not hearing any other people chime in, so I guess you did a good job, Harriet. Thank you. Okay, well, let's hear from our French-speaking group. Are you there?
They said in the chat that they're ready to talk.
So whoever is reporting for the French-speaking group needs to unmute your mic so we can hear you.
So the reports of the reports of my main groups or small group discussion. So I was talking to Zachary. He is from Africa. He is a similar reports and so the best things is the CBIO methodology. The best things, the CBIO methodology is
could you please turn your camera off, and it might help the audio if you could try that. If somebody could say that in French.
Stop this video.
Speaking English.
There you go. If you turn off your camera, I think
somebody said they
the best things
we can't hear you.
We can't understand what you're saying. It's very garbled.
Sorry. Maybe type it in the chat.
bad connection there. So let's say CBIO est une méthodologie qu'on doit appliquer dans la population urbaine. Et c'est une bonne méthodologie. Mais il faut accompagner les CBIO avec d'autres choses. Parce que lorsqu'on a réalisé dans la discussion les problèmes qu'on a rencontrés en Haïti et dans l'Afrique, dans le groupe pour travailler M. Zachary, on a rencontré les similaires problèmes, même problème. La population est pauvre, mais quand on a fait l'éducation, on n'a pas accompagné les CBIO avec un programme de nutrition pour faciliter les aliments nutritionnels vers la population, ça va poser beaucoup de problèmes. Mais qu'est-ce qu'on doit faire pour solutionner ces problèmes? Il faut travailler et convaincre la population. Convaincre la population vers l'éducation et supporter la population à comprendre des liens à vivre avec leurs propres moyens. C'est cela la facilitation des CBIO. Les CBIO, on a réalisé les CBIO peuvent changer les comportements. Mais aussi, on doit utiliser la méthodologie de CBIO pour réduire les cas de mortalité dans les pays pauvres ou dans la population urbaine. surtout dans la communauté où je travaille. Merci.
Okay, go ahead.
Aeneas, we need to stop you. We can't understand, and our French interpreters cannot understand either. The connection is not good, so I'm sorry about that, but we'll need to move ahead. Is there another French-speaking group? There was somebody else who was trying to unmute themselves and couldn't. Who was that?
That was earlier.
Okay, is there another group that has not reported yet? Hirshad Chowdhury. Hirshad Chowdhury, can you unmute yourself and report, please?
Thank you very much to Dr. Henry. So at last I could unmute myself.
We hear you.
Go ahead, we can hear you.
Oh, yes. I was in one of the groups, probably the English group too. And I wanted to add 1 or 2 points with them, but
sure,
I could not do that. So in that group, I was trying to say that one of the challenges that I think that we'll be facing in to engage with the community. So community engagement or encouraging the community to take part in this kind of CBIO approach may be one of the major focus for this kind of approach, and to encourage community to take part in this kind of surveys, and then we can ascertain that what kind of needs they have, and we can prioritize the needs, and accordingly we can provide health services. A second point I also wanted to add is about a public health campaign. So conducting public health campaigns that target a wider audience through various media channels. So that can be another approach, and promoting the health awareness and encourage community members to seek healthcare services. So these are the things I wanted to add. So I couldn't. Well, that's
okay. Well, thank you very much. Where are you calling from? Are you from Bangladesh?
Oh, yes, I'm from Bangladesh, right.
Very good. Thank you. Who has not reported yet from your group? Is there a group that has not yet reported?
The French group, Troy Senon can report. Troy can report from the French group.
Okay, so we understand that Troy is speaking on behalf of the French group. So please unmute yourself and speak, Troy.
Oh.
We do not hear anything, Troy. Have you unmuted yourself? We don't hear anything.
Hello, yes, this is Troy Senon from Haiti.
Can you speak a little louder and speak slowly? It's not coming through very clearly.
This is Troy from Haiti. I just want to summarize the last report by Anais for the